Uh, so for that purpose, we thought that this is the right way to go. आप लोगों ने ही इस पे work किया है, तो you will probably be have a better tuning with the clinicians to be able to give them the grasp of understanding of how you diagnose and uh, how it, how it is will be possible for them to work in this area. So in the morning we
Okay,
have this session with you, and then in the afternoon we have a session with Dr.
Ankit.
Ankit Verma. Yes, so वो pediatric session का है और आज
Because we
morning.
see these kind of cases now we see. Earlier
Yes,
also when I was doing residency from Lucknow,
जी जी.
KGMC also we get a lot of heat stroke patient. In fact,
Yes, yes.
uh, they have a dedicated, I remember being back in day 2001 to 4 when I did my MD from
जी.
there. We had a dedicated small, very small room with 3, 4, 5
Yes,
ACs, very strong. Yeah, so
yes, yes.
difficult part is the differential diagnosis actually. You lot of time you don't know
हाँ
whether
हाँ. Right.
I
वही
have made sure that हाँ मैंने कोशिश की है कि उन्हें
जी, इसी को
प्रैक्टिकल
एड्रेस
एक्सपीरियंस
करवाना। तो
जी जी
उससे इसलिए है कि हीट स्ट्रोक्स होते हैं, इसमें कोई डाउट नहीं है, पर रिपोर्टिंग करते समय क्लिनिशियंस अपने इस क्वेरीज की वजह से उसको मेंशन नहीं कर पाते रजिस्टर में या किसी वजह से, जिसकी वजह से वो फिर रिपोर्टिंग सिस्टम में रिफ्लेक्ट नहीं हो पाते। तो वो जो आपको वो कॉन्फिडेंस बिल्डिंग स्टेप्स इनमें देना है ताकि वो रिपोर्ट हो, एंड देन वी आर एबल टू अकॉर्डिंगली टैकल दी, वी अंडरस्टैंड कहाँ पे बर्डन है और कैसे उसको एड्रेस करें। तो आपने जैसे बताया कि वार्ड्स हैं, तो अभी हम जब अहमदाबाद गए थे तो वी वेंट अक्रॉस सम ऑफ द प्लेसेस इन अहमदाबाद, और वहाँ पे भी चाहे कम्युनिटी लेवल सेंटर हो चाहे हॉस्पिटल हो, उन्होंने भी एक हीट स्ट्रोक वार्ड्स बनाए हैं। तो
हाँ
ये बहुत अच्छा इनिशिएटिव है, एंड आई एम हैप्पी कि आपने अपना भी एक्सपीरियंस शेयर किया। तो दैट्स आई थिंक इट्स आल्सो समथिंग, इफ दे ओनली रिकॉग्नाइज द रेलेवेंस ऑफ इट, तो फिर वो इन प्लेस
जी
आता
जी
है।
जी
जी।
जी
Good morning, everyone. We are starting in 2 minutes.
All those who have raised hands, if they have anything specific to say, please write it on the chat box, please. And if it's an accidentally done, can you please lower your hands? You're not getting an audio because we are yet to start. We are waiting for some more participants to join. Meanwhile, all of you can have access to the link that has been provided in the chat box of the National Action Plan on Heat-related illnesses. It is this action plan that we will be talking in details today with our invited speakers. Then we'll start at 11:05. Let's wait for 2 more minutes. Okay. So we have now almost 200 plus attendees in this program, and we hope that they join more very soon. But let's begin the session. Good morning, everyone. I hope I'm audible to all of you. And welcome to this special training program for the master trainers of clinicians. This training is about the clinical aspects of heat-related illnesses and deaths. And we here are in the National Program of Climate Change and Human Health. The participating participants are program officers of this in the states and the districts, as well as the master trainers, clinicians identified in the states and the districts who will take forward this training to participate in the heat-related activities of their own states, and also in turn to train the other clinicians and medical officers who have not been able to join today's training session. The training is about the National Action Plan on Heat and Health, which was recently developed and launched by the Honorable Union Health Minister of the country in July 2021. We also have been implementing and heat-related surveillance of heat stroke and deaths in this country based on the new formats that are there in this book. While we were implementing, one of the major concerns that came up from the program officers across the country, from states and districts, was the challenges in the clinical protocol of identification of cases of their being registered so that they get counted in the surveillance systems, the treatment protocol, and other challenges related to the clinical aspects of identification of illnesses and deaths. In this regard, we have today invited an eminent speaker, Professor Ajay Chauhan. He is a professor in the Department of Medicine at the Atal Bihari Vajpayee Institute of Medical Sciences and Ram Manohar Lohia Hospital in New Delhi. He is one of the distinguished committee members who participated in the uh, drafting of this National Action Plan's critical protocol. He was uh, very enthusiastic throughout this some work that we were doing, and one of the chief contributors in drafting that clinical protocol. And with his immense understanding of this subject, I think he will be able to bring highlights about what are the main aspects that needs to be covered by clinicians when understanding cases related to heat, and the deaths, how to identify the deaths related to heat. So with this, I will request, with now more than around 260 participants on board, Professor Ajay Chauhan to please initiate his session. He will be speaking about the adult cases, and then we have an afternoon session today beginning at 2 o'clock, when we will have another eminent speaker to join with us. We'll be talking about the pediatric cases. So over to you, Professor Ajay Chauhan.
Thank you, sir. Thank you. See, I am unable to screen share.
Okay.
Kindly enable me to share my screen, sir.
Okay. Dr. Purvi?
Sir, I think you are the host. It should be done from your side.
Have you given him the rights now?
No, sir, you need to do it from your side, I think.
Okay, from my
You are
side.
the host. Yes, sir.
Yeah.
Have you now got it?
No, sir, I haven't. Post disabled participants
अच्छा,
screen sharing.
अब देखिए,
मैं एक बार करता हूँ दोबारा.
आपको को होस्ट बनाया है, अब
हाँ
देखिए,
हाँ.
अब है
Yeah, yeah.
ठीक.
Now I am
Okay.
able to.
Okay, thank you.
So good morning all. Am I audible?
Yes, you are, sir.
Yes, sir.
Okay, thank you. So dear colleagues, wherever you may be sitting, you may be in states and districts, and you may be master trainer, you may be trainers. I welcome you all for this virtual training session on heat-related illnesses under the aegis of National Program on Climate Change and Human Health. So in this, I would be covering the entire bracket of heat-related illnesses, ranging from mild to the severe ones. We will, at the middle of the session, will have case definition of some serious illnesses, including their diagnostic workup, the challenges which we come across in clinically managing them, especially the differential diagnosis. I would like to briefly touch upon the clinical knowledge and protocols. And at the end of our session, we will have HRI death investigation and data collection from clinical history and medical records. So let's identify the magnitude of the problem. India, half of India is a tropical country. I mean, India is bisected by Tropic of Cancer. So, and we are a hot and a moist country. So both these factors play a very significant role in emerging number of heat-related illness. And on the top of it, we have now extreme climate events, global warming. So the extreme weather events are rising everywhere. As you would have noticed, some decades back, we had a lot of cyclones in from Bay of Bengal area. But nowadays, if you follow the news carefully, we have something arising out of our western side also in Arabian Sea. So these are all the consequences of various climate change things. And being a tropical country and on the top of climate change, we will have this problem in growing magnitude as years go by. Keeping in view all this, since 2015, IDSP, and now we have this National Program on Climate Change and Human Health, and which is compiling data on heat-related illness and deaths due to HRA. Earlier, it used to be from April to July, and because of increasing heat in bunch of March itself, we have revised it from April to March, every year from 17 vulnerable states. And since 2019, it has been escalated to 23 states. And a total number of 3,775 deaths were reported during this 5 years period, which makes average ballpark figure of about 800 deaths per year. But we all think that it is a underreported figure. Real magnitude might be much more. And we, as this program intends to sensitize people in reporting and identifying the deaths due to HRIs. So heat-related illnesses are a spectrum of disorders ranging from very mild to very severe one, which can cause fatality. And this is basically a mathematical problem. It arises when there is a disbalance between input and output. Input means from both environment as well as the body, and output meaning the body mechanism of heat dissipation. So whenever they are out of sync with each other, maybe due to environmental reasons or due to bodily reasons, we have this problem of heat-related illnesses. So to begin with, let's discuss something about input. And since the thrust is on climate change, we will start with the heat related, which is the external input. Heat wave is defined as a departure from normal temperature in excess of 4.5 to 6.4. And over and beyond 6.5 degrees centigrade is severe heat wave. And there's one more definition, which is based on actual maximum temperature. But these are ambient temperatures, which is heat wave is when the actual maximum temperature is greater than 45. And we call it a severe heat wave when actual maximum temperature is greater than 47. And a heat wave, in order to be declared, has to be, there are three criteria. It is declared on the second day. If the criteria are met for 2 consecutive days on 2 stations in a meteorological subdivisions. Weather department have this subdivisions of various meteorological stations. If it is reported from 2 stations on 2 consecutive days, we declare it as heat wave on the second day. So there is one more very important thing to be learned by us clinicians. Usually when we see temperature, it is not the ambient temperature which matters. We have ambient temperature, which is the temperature of the air, and then we have a more comprehensive wet bulb method, which is wet bulb globe. So let me tell you the difference. While ambient temperature measures only the temperature of the air, wet bulb measures, as you can see in the picture, it has a black colored bulb which measures solar radiations. It has in the middle has an evaporative thermometer which measures wet temperature, and in the on the right side is a normal ambient temperature. So based on all these things, airflow, solar radiation, and the temperature itself and the relative humidity, we come across a temperature which is more in sync with our physiological or disease state, which can cause a disease state of HRI. So I have again incorporated a slide screenshot actually from my computer. This is you must be noticing that there are 2 temperatures, 28, and below that is feels like 32. Feels like 32 is a amalgamation of not only the temperature but humidity, as well as the airflow velocity, as well as the radiation. So in all the events, suppose there is a marathon going to be held, it is this temperature which matters. So now we come to another part of the input puzzle, which is endogenous, which is bodily derived. So, and in bodily derived, exercise produce a great amount of heat generation. And external exercise can increase the heat generation as much as 20-fold. Actually, when you see human physiology, nature has endowed us with great physiology. So a good trained athletes can go up to 30 METs on a given day. 30 MET is when the oxygen consumption in rest, which is about 3.5 ml per minute. So in a sternus exercise, people can, highly trained athlete can really produce a lot of heat. So this is the endogenous factor besides the weather, which is the exogenous. Now, once having discussed this input, now let us see various output method. How is heat dissipated from our body? How does body cope with this excess heat? And we have 4 mechanisms. 3 we have all read in physics: conduction, radiation, and convection. But the most important in which our body thrives upon is evaporation. This is the most efficient mechanism, but it has also got one limitation, that it becomes ineffective when the relative humidity rises to more than 70%. So it is not only the heat which matters, it is the humidity which also matters, because it knocks down our heat coping mechanism. On the top of a wet skin, when air flows, there is a lot of cooling generated and skin vessels get dilated, so that this lower temperature is carried to the central body. Then we have conduction, which is by touching cold objects. And this is a very surprising fact that thermal conductivity of water is about 25 times greater than that of air. It means if somebody, God forbids, falls into a cold lake, maybe in colder parts of a country at 0 degree, and the temperature of air is also 0 degree, that air will bring his temperature down 25 times lesser than what water will bring it down. So it is a very, and this mechanism we use in one of the methods of cooling, which I will discuss later on, which is called as the immersive cooling, which has its pros and cons. We'll discuss them later on. Then we have two other mechanisms, convection and radiation. These are minor methods. In fact, radiation is the major source of heat gain rather than heat loss. So convection is when air flows over our skin, then air takes away. If air is cooler and our skin is warmer, heat flows. So how does our body regulates temperature? This is very, very essential to know basic physiology, because if we don't know it, we will never be able to understand the difference between fever and hyperthermia, which again is a diagnostic challenge. So basically, the hypothalamus comprises of two sensors. It takes input from two sensors. First is the blood flowing in the hypothalamus, and second is the peripheral sensors, which are peripheral thermoreceptors. And hypothalamus, the brain area concerned with thermoregulation, compares the two temperatures. And based on the difference, it knows whether it is hot or cold. So it, in order to ameliorate this problem, it solves it by a couple of mechanisms. And we will talk about hot, which is increasing cholinergic sympathetic nervous stimulation, thereby increasing transpiration and vasodilatation. If reverse happens, if we are surrounded by cold, the reverse happens, which is the noradrenergic system activates and there's a vasoconstriction. And moreover, there is a central mechanism which causes somatic muscles to shiver and thereby increase heat production. So it is the hypothalamus which controls what temperature will the body, what will be the body's core temperature. Now, this is a slide which I incorporated from a textbook, which is very, very important. What is the difference between fever and hypothermia? If a patient comes with us with a very, very high temperature, we are always confused. Sometimes it is very difficult to make out whether he was having fever or hyperthermia. So we must know the basic difference, and more so the fever. I have incorporated one variety of fever, especially in my slide, hyperpyrexia, because there's a very confusing term. Hyperthermia, hyperpyrexia, very very similarly sounding terms. So in fever, basically there are pyrogens in our body. Pyrogens are anything which cause our hypothalamus to raise the set point, are a pyrogen. Pyro is fire and gen is generating, increased temperature. Now, what can be these pyrogens? It can be endotoxins because of bacterial infections. It can be various inflammatory conditions like chronic liver disease. Also, people have fever. In some connective tissue disorder, there is a fever. These are because of interleukins. So whenever there is a signal to hypothalamus, okay, you increase the set point, we require a higher body temperature in order to knock off the bacteria or the inflammation, then it is called as fever. In fever, hypothalamic set point increases. So hypothalamus asks body, even if it is 101, 102 degree, which is obviously abnormal, hypothalamus asks the body, okay, you raise temperature further by shivering, by feeling cold so that we take on more blankets. In hyperthermia, however, there is no change in the hypothalamic setup. Actually, hypothalamus is knocked off totally. Hypothalamus wants your body to be at a normal temperature, but so much is the difference between heat input and heat output that bodily functions are unable to dissipate the heat. So there is no set point. And because there is no set point, the way antipyretics work are, they decrease the amount of pyrogens in the body. But in hyperthermia, we have no pyrogen. In fact, hypothalamus is never asking the body to raise temperature. So it is a disbalance between body ability to generate heat and dissipate heat. So that is called hyperthermia. Now, again, a very, very interesting question. What is hyperpyrexia? Hyperpyrexia is a type of fever. It has nothing to do with hyperthermia. These are very, I will request you to pay close attention. When there were no antibiotics back in the day, 200 years back or 150 odd years back, I think more than 200. I may be wrong or right, you can check it. So before the advent of antibiotics, there is a limit up to which hypothalamus can raise this set point, which is 106.7. A normal human doesn't, even no matter how much severe the infection is, hypothalamic set point cannot be increased above that. That is near about the highest which it can get. So hyperpyrexia is that limit which hypothalamus. So I hope that this slide clears the pathophysiology as well as the treatment approaches to fever versus hypothermia. In fact, cooling, as we will discuss later, solves a lot of our diagnostic dilemmas, whether it is hyperthermia, which is something else. Cooling is the, very important. We'll discuss it. So now we have talked about input, output. Then human body is a great machine of nature. So how does it acclimatizes? And so you will be surprised to know that human body have tremendous ability to acclimatize itself, both in cold as well as hot surroundings. So what are these various acclimatization mechanisms? Just a second. So one thing is very important. Acclimatization takes several weeks, while as deacclimatization takes a few weeks. So if some army person comes to you and he says, Ki bhai, I run 20 kilometers a day and I've been running in my training and I can take on this heat, this, that. But you should ask him or her, how long have you been on chutti? How long, if it has been 4 to 6 weeks that he has been sedentary, his exercise capacity or acclimatization of heat may be lost. So it builds up very slowly, but it wanes away very, relatively quickly. So we have to be very cautious of that thing. And these are the people who come to us with exercise heat stroke, actually. These are two variety, classic and exercise. We'll discuss later on. So acclimatization, another procedure of acclimatization is that thermoregulatory set point is altered. I mean, hypothalamus at a relatively lower escalation of temperature increase to produce a higher sweat rate. And see, the sweating rate can increase up to 1 to 2 liters per minute. That is mentioned in our textbook, Harrison's. But when I read through net various articles, in somewhere it is mentioned as in Australian Open 2 to 3 liters per minute also. Can you imagine? You multiply 3 by 24. It is about 72 liters a minute. See the beauty of human body adaptation. And besides these two mechanisms, we have certain cardiovascular adaptations also, namely plasma volume expansion occurs. And there is an increased cutaneous vascular flow. In all the people engaged in manual labor, you must see that there is a lot of sweating, even when they are resting. That is because of the increased cutaneous vascular flow. And heart rate lowers with a higher stroke volume. That happens more or less in all the athletes. I'm sure that someone amongst you might be, a marathon runner. You would have noticed it. There is a vagomimetic effect of exercises, which higher our heart becomes stronger and stronger and the rate gets lower. About 12, 13 years back, before joining this as faculty, I used to work in HAL, which makes this fighter airplanes. And I had the fortune of doing TMT of a gentleman known as Rakesh Sharma. You would have all people of my generation would have heard his first Indian in space. And you would not believe that his heart resting rate was at 60. He must be 62 then. Back then I was 30, 32, 35. And then his heart rate was 50, 55 at that age also. And very high stroke volume. So human body is a significant marvel of nature, but we should not test its limits. So what are the predisposing factors and differential diagnosis? So various predisposing factors are laborers, military personnel, or athletes with poor conditioning or lack of acclimatization. No matter how strong have you been, but you have to be acclimatized to heat. And then one more thing is extremes of age. My dear colleague, Dr. Verma will discuss the children part of it. And we deal in geriatric. I will touch briefly on that also. And on the top of actually the problem with older age people is most of them, unfortunately, in India are taking some kind of medicine also. So that also plays in a factor. And for the poor segments of our population, there is a big problem of malnutrition. Plus, there is a poor physical fitness in these days and age. And we have some drugs. There is a whole big list of drugs, but I have only mentioned those drugs which are, as clinician, we see day in and day out. I can bet whosoever is sitting must have prescribed this medicine in abundance. Be it the beta blockers, every second person takes for hypertension, calcium channel blockers, diuretics, and we have SSRIs, which are antipsychotics. So these are commonly used drugs. There is a whole bunch, but it is very difficult to remember that all. So basically, these are the common ones. So we should all be alerted. If a person is taking beta blockers, or he's taking amlodipine or metoprolol or some kind of sertraline. So very commonly thiazide diuretics are used in LD. So you have to be sensitized. These are more prone to get heat strokes or heat related illness. And then there are very important category of substance of abuse, namely cocaine, amphetamines, hypnotics. And I deliberately mention ethanol is in the last because it is the most widely consumed ones. It's last but not the least. So of every heat stroke patient, we should take a history of ethanol consumption. And this is there in the diagnosis of death related to HRA. We'll discuss in the last leg of our presentation. And simultaneously, we should inquire about concurrent infections. Diabetics may have a DKA. Thyroid storm is rare, not very common, but still we should take in the proper history. And CVD. And this is the very striking line. Actually, everybody should take a moment and read this one. Cerebrovascular accident and myocardial infarctions occur at least 10 times more often in the conditions of extreme heat. You just take a pause and swallow that line up 10 times. And those whosoever has worked in medical emergency during the internships or residency training, we have there is an epidemic of CVDs and MIs, and 10 times more common. And though it will be a bit speculative, and don't quote me, it is off the record, but see, we have just had a episode of a singer dying, very popular singer. Okay, and what were the mitigating circumstances? You look at it carefully. Lot of 4,000-5,000 people in a room made for 1,000 people. And in the hurry and worry, he is singing, dancing, engaging the audience. Humid, moist, and the top of it, there were some news report that the AC went off. And now read this line again. Cerebrovascular accident and MI occur at least 10 times more common. I don't claim anything, but that is a thing to ponder upon. So now, after telling you the magnitude of the problem, the basic pathophysiology, the acclimatization, let's now come to HRI proper, which is actually a spectrum of disease ranging from some very minor things to nearly killing things. These minor heat syndromes are 4, namely heat edema. And we have, I will start with prickly heat or miliaria or lichen tropicus. I know this is a pan-India audience, but in this North Indian states, we called it as ghamori. Very common word, I'm sure. So everybody I had at least 2-3 times in my childhood. So we are all, but there are some differential diagnoses to be considered. I'll discuss them. And then we have heat syncope. This also is relatively common. Everybody of us, most of us कि भाई ये बच्चा हीट असेंबली में खड़ा हुआ था, डॉक्टर साहब, स्कूल की असेंबली चल रही थी और एकदम गश खा के गिर पड़ा. या I have an army background, so people, they say he was standing in the parade and then he fell off, this Jawan. So we have all have snippets or vignettes of these kind of history also. And there are two relatively uncommon conditions, at least I will admit. I have not seen them frequently. I am sure that you people would have seen them in abundance, which is hyperventilation tetany and heat edema. Nonetheless, we will discuss about it. Then we have another condition, and in order of severity, these are heat exhaustion and heat stroke. So let us discuss all these things one by one. Prickly heat, also called as miliaria rubra or lichen tropicus or heat rash in colloquial terms, is a maculopapular pruritic erythematous rash in clothed area. So it is not vesical or pustule, it is maculopapular. And I am sure that you would all understand. Maculopapular, not vesical, not pustule. So it rules out a lot of poxes. Okay. Not vesical, not vesical, not pustule. And then how is it caused? It is caused by the blockage of sudorific duct, by the debris of macerated stratum corneum. And the predominant symptom, as we all know, is pruritus. And the treatment is very simple. Ask a person to wear pure cotton clothes, loose fitting, breathable. And if a person suffers, then we can prescribe him or her antihistaminics, and we can have some light ointment, namely the chlorhexidine or salicylic acid, TDS. And it goes away. Even if you don't do anything, it goes away on its own. But if you want to accelerate, it will go faster. One of the important differential diagnoses is contact dermatitis, in which same kind of maculopapular rash arise, but then the difference is the area, not the clothed area, and there will be a history of contact. A person will be wearing some kind of a bangle, metal bangle, ring. So the contact dermatitis CD happens there. One of the common is scabies also, but that happens in intertriginous areas, hands. So it is pruritic intensely, same as this, but with the provident, slight amount of prudence, it's a very easy diagnosis to make. So let's come to heat syncope, which is relatively commoner. It is also called as exercise associated collapse. And it happens after endurance exercise or prolonged standing in elderly. And there may be a lot of comorbidities. The cause of this is relative volume depletion and decreased vasomotor tone and peripheral vasodilatation. So I would, there is one thing which I want to focus upon. See, syncope, heat syncope is, first line is following endurance exercise. This is a thing we should take a moment to. There is an old saying that runners can run, but they cannot stand. If you speak with a lot of people who are engaged in marathon running, whenever they finish a marathon and they stand, they suffer, or in a resting condition, when they stand up quickly from a lying down position, they suffer from a severe initial orthostatic hypotension. And this is unlike orthostatic hypotension. There is a difference between orthostatic hypertension and initial orthostatic hypotension. Initial is 99% physiologic, and orthostatic hypotension we measure by a person stands and we take his or her BP after 2 to 3 minutes. And initial is within 15 seconds. So you may wonder, अरे वैसे तो ये आदमी बड़ा, I hope that some Hindi you will understand. बड़ा मजबूत था, लेकिन ये तो यार खड़ा होके ढह गया धूप में. तो that is because of his increased vasomotor tone because of exercise induced. So that is more prone to heat syncope. That is why you must have noticed that these army jawans who are otherwise very fit, infantry jawans can run with a pittu for 20-30 kilometers. But sometime during exercise, when they have to stand for a long time, they just collapse. So that is very pertinent to know. And the treatment is very, very simple. Simply remove it from heat source, lie him or her down. And this is a common recurring theme which you will again and again and again hear from me, which is cooling. Cool him, cool early. And last but not the least, rehydrate him. Preferably most 99%, 80% people will recover from oral rehydration. Seldom require IV fluids, but if need be, you can give it. Now I come to a condition, I don't know the statistics of this. I tried to look at, but I have very less encountered this. It's called as hyperventilation tetany. I have seen cases of hyperventilation tetany. A single person experience is not an epidemiologic thing. With this disclaimer, but most of the things which I have seen in my practice is about anxiety-induced hyperventilation tetany. I have seen young females, about 10 cases in my entire cohort. But heat-induced is something which I am yet to see. So the mechanism is more or less similar. When exposed to heat, people have this increased respiratory rate. Respiration, it produces respiratory alkalosis, as we all know, decreases calcium, causes paresthesias and carpopedial spasm. And unlike, so there is a difference between this kind of spasm and heat cramps. Heat cramps is next when I will discuss after heat edema. After this, I will tell about heat edema, then heat cramps. So unlike heat cramps, how do we differentiate whether it is a heat cramp or a tetany? So you will have history of hyperventilation. And second, most important is heat cramp will have pain. Whereas hyperventilation, tetany, because of increased heat, doesn't have pain. So that is a very important difference to note. And on a clinical experience basis, this is a relatively less commoner condition. Heat cramp you will encounter a lot, but tetany, I mean, if you see a lot of patients, you can. So, and treatment is very simple, providing reassurance, moving the patient out of heat and addressing the hyperventilation. When you provide reassurance, then people stop hyperventilating. Sometime in anxiety tetany, uh, a simple injection of normal saline given IV slowly with lot of suggestion to the patient, okay, I'm giving you a very good injection, it will take away all your problems, is able to solve the problem, which we have done. So, and if the kidney doesn't resolves, or a person has a predisposing condition, like a person is having CKD, which as it is people have a low calcium, then you can obviously give calcium. Calcium simple 4 to 6 ampules in 10% dextrose over 6 to 8 hours. So after this, we come to heat edema. This is also, I have not seen it much, but it is mild swelling of the feet and ankles. And in first, after significant heat exposure, it occurs in first few days. And the reason for this is it entails cutaneous vasodilatation, which increases pooling of interstitial fluid. It also, one of the pathophysiology is increased heat increases ADH and aldosterone. So it causes hands and feet to swell up. But before declaring the edema as secondary to be caused due to heat, we should rule out other very important causes of edema, namely cirrhosis, nephrotic syndrome, and CHF. And these are very, very simple things to rule out. It doesn't, cirrhosis, all of us will be, it's nephrotic syndrome, CHF. Look at the ECG, ejection fraction, everybody will be able to tell. So generally resolves without treatment. It doesn't require treatment. The main reason why should we identify it is it doesn't require diuretics. Simple leg elevation or simple compression measure usually suffice. And diuretics, in fact, predispose to volume depletion. So you should not give diuretics. Since the condition has an uncanny similarity to other causes of edema, namely cirrhosis or nephrotic syndrome. It is actually, rather than ruling it in, we have to rule out other causes. And then it makes our life easier in managing these patients. Now we come to a relatively commoner condition. Everybody of us has have had patients of heat cramps. Heat cramps, or is in simple language, exercise associated muscle cramps, are intermittent, painful, and involuntary spasmodic contraction of skeletal muscles. It typically occurs in an unacclimated individual who is at rest after vigorous exertion in a hot, humid environment. So acclimatization provides a great buffer against heat cramps. And the persons who are most likely to have these heat cramps are roofers. Roofers is a relatively uncommon English term, so I looked at it. Roofer is people who lay roofs. I don't know how much of this is relevant here. Roofer, but roofers are those who lay roof of something. It's a Western thing. And then firefighters, obviously, they deal with a lot of hot and humid, multi-personnel, athletes, steel workers, and field workers. Steel factory has also a lot of heat and humidity. So these patients are profusely diaphoretic. Diaphoresis is an extreme amount of sweating and has been replacing fluid loss, which is copious, with water and other hypotonic fluid, and therefore creating a sodium imbalance. That is the reason of heat cramps. So it appears because of relative deficiency of sodium and potassium also, and fluid at an intracellular level. And usually the response of a person is to ingest a lot of water, but people usually forget to ingest the electrolytes lost. And as a you must have all seen this. Those of you who are interested in lawn tennis, you must have seen these people eating banana. Roger Federer, usually electrolyte Gatorade solutions with banana. Banana has a lot of potassium. So they not only replace their fluids, but replace their electrolyte ones. And in exercise alone, there are some cramps that can due to exercise alone, even in cold weather. They are relieved by stretching and massage. And these heat cramps are not relieved by stretch and massage. This is the difference. And most of the time we use flavored electrolyte solution, which is there in our health centers, primary flavor, that is ORS. And we can have salt tablets also dissolved in water. One more thing, you should not take salt as it is. It is a severe gastric irritant. It may produce vomiting, which defeats the purpose. So salt is also always taken in this dissolved form. Now, from heat cramps, we come to the last two conditions, which is heat exhaustion and heat stroke. I will speak about heat exhaustion first, followed by heat stroke, which I will give maximum time to. But first slide is dedicated to the difference between these. Sometimes it is difficult to differentiate between these two. So this is the first slide entirely dedicated to the differences. So what the basic difference between heat exhaustion and heat stroke are two. First is in heat exhaustion, there is some semblance of maintenance of thermoregulatory control. But in heat stroke, this is totally knocked out. And what happens as a result? As a result, the core temperature of the body rises to greater than 40.5 degree. See, in guidelines, we have put it as 40 degrees. But so it is 40 to 45, 40.5 degrees. You can, okay. And if core temperature is below 40.5 degree or 105 degree Fahrenheit, it's more likely to be heat exhaustion. So we have two differences because a lot of common neurological symptoms also occur in both these two conditions, heat stroke and heat exhaustion. But as you would learn later on that in exhaustion, even the neurological symptoms are milder ones. I will highlight them while discussing. So heat exhaustion, we have two kinds of heat exhaustion. Water depletion heat exhaustion, and salt depletion heat exhaustion. Water depletion heat exhaustion occurs in laborers, athletes, and elderly individuals. These guys exert themselves in hot environments, but they don't replace it with adequate fluid amount. They replace it, but not adequately enough. So there is a relative water depletion. And these are, since all these category of people, labor athletes, they know that they have to take water because they are kind of acclimatized. So they replace water, but there is an inadequate replacement. And then there we have a salt depletion. These occur usually in unacclimated persons who just consume a lot of hypotonic solutions. The water depletion one is in those people who just consider themselves ki bhai, let's not take water. Let's pull on for another 1 hour. Let's continue working. Or they ignore their needs. And this is in an acclimated person. They take hypotonic. They replace only water, but not the salt. So there's the basic difference. And there are sign and symptom of heat exhaustion, neurologic. It's milder than heat stroke. See, the person is suffering from heat exhaustion. He may or she may have headache, vertigo, impaired judgment, malaise, dizziness, cramps, and in severe case, some kind of ataxia also. If you carefully examine by finger, nose, finger method or Romberg's method, you may find a bit of ataxia also. But these are milder symptoms. And when we go to that section of heat stroke, you will have symptoms like unconsciousness, seizure, and so on and so forth. So these are milder than heat stroke, and the temperature is lesser than 40 degrees centigrade. Besides this, in heat exhaustion, we can have influenza-like symptoms, GI symptoms of diarrhea, frequent diarrhea, along with nausea. In CVS, we can have orthostatic hypotension along with sinus tachycardia. When we investigate these patients, we have hemoconcentration. The packed cell volume is up, hematocrit, and electrolytes are down because of salt depletion. And hepatic aminotransferases, or ALT or AST, or in earlier, if you use the earlier term, SGOT and PT, are elevated, but mildly so. In heat stroke, they will be elevated by 100 times, like upper limit of SGOT PT is 40, so they will be 4,000, 4,500, hundreds of times. These you will get 2 to 3 times, 4 times normal. And if you look at urine sodium and chloride are low. This is as a result of body's mechanism to conserve these cations and anions. How do you treat heat exhaustion? As the recurring theme of the day, remove the patient from heat stress area and aggressive cooling. This is a common theme which you have to do for every patient. And until the core temperature is about 39, we don't cool a person to 37. That is important. So there's some after cooling also once we are done with the cool. So, and the various methods of cooling we will discuss in the last, which is heat stroke. And then we can give a person rapid infusion of isotonic fluids guided by the electrolyte imbalances. Suppose some person is having hypernatremia, loss of water, then we can give 0.45% saline or 5D. If a person is hypernatremia, then we can hyponatremia, then we can give normal saline. You have to guide this. This have to be guided by the lab reports. And one very important thing is this, that free water deficit should be replaced slowly over 1 to 2 days in order to avoid a decrease in serum osmolarity. We should not never, ever correct electrolytes too quickly. We are all taught this thing. So we have to be very cautious. We should not decrease serum osmolarity by greater than 2 milliosmol per kg per hour. So we have to be very cautious. And I have incorporated from that. This is all in the guidelines, but there's one thing which I have incorporated extra. How do you calculate serum osmolarity? So this serum osmolarity is a simple formula. I will give you these slides after my presentation is over. 2 times sodium plus plasma glucose divided by 18 plus urea divided by 6. In Western countries, they use BUN, which is 2.14 times the urea levels. Urea divided by 2.14. So their calculation is different. I have modified this equation according to Indian things. Most of the time which use urea. So this equation contains urea, which is simpler one to use. So you can calculate the body osmolarity and correct it slowly, not more than 2 osmoles per hour. Then we come to the final and the most lethal of all conditions, which is heat stroke. Heat stroke reflects a total loss of thermoregulatory function. And as a result, core temperature is usually in excess of 40.5 and associated CNS dysfunction. And then this is very, very important that we measure there is no place of cutaneous monitoring, tympanic thermometers, axillary thermometers in managing a case of heat stroke. Everything has to be done by core body temperature. The best way to measure it is rectal thermometer. And if at all we don't have it, then oral plus 0.7 degree Fahrenheit correction. But the best way remains core body temperature checking is rectal thermometer. So heat stroke has a mortality rate as high as 30 to 80% and is universally fatal. It will result in a death if we don't act, and if we don't act fast. So it is a diagnostic. How do we diagnose heat exposure, heat stroke? It's a triad. One, there is a exposure to heat stress. Second, there is a CNS dysfunction in form of coma, seizures, altered sensorium, irritability, agitated behavior. And then, most importantly, there is an increase in core temperature of over and beyond 40.5 degrees. So, lot of times, even in this triad, now I will tell you a vignette of a real life scenario. A patient comes to you, somebody carries it to your emergency in a CHC or a PHC or a medical college. कि भाई ये तो बिल्कुल बेहोश पड़ा था और तप रहा है जी, बाहर गिर पड़ा काम करते करते. Now one of the very difficult things is to see कि भाई ये इससे पहले निमोनिया तो नहीं था, कि ये सिस्टिक इन्फ्लेमेटरी रिस्पॉन्स सिंड्रोम का पेशेंट है, इसे इन्फ्लेमेशन हो रखा है और फिर गिर गया है. तो ये these are real life scenarios, they were not simple and easy. And second, जैसे कोई भाई आप गए राजस्थान के कुछ रिमोट एरियाज में और ये आदमी गर्मी भी पड़ रही है लेकिन झाड़ियों में सांप भी है, तो ये कैसे पता होगा कि भाई सांप भी तो काट सकता है, उसमें आदमी बेहोश भी हो जाता और उसे मसल क्रैम्प्स भी, मायोटॉक्सिक स्नेक. तो ये रियल लाइफ सिनेरियो है. तो इसमें हमें जो सबसे विच इज द मोस्ट इंपॉर्टेंट थिंग इज कूलिंग, टू कूल अ पर्सन. If it doesn't responds by cooling, there is not even a slight bit betterment, then you think again. And we have actually differentiated one case of snake bite from heat stroke by this. So I'm telling you the real life anecdote. So now what are the systems involved? CNS I have mentioned in great detail: altered mental status, slurred speech, irritability, agitation, seizures, coma. Mind you, all these conditions are more severe than what we discussed in heat stroke. And if now again, I have mentioned in bold letters, if the patient mental status does not improve with cooling, then your other reflexes should kick in. Then you can do a toxicologic screening, cranial CT, spinal fluid analysis. Basically, heat stroke is a diagnosis of exclusion. There is no perfect remedy. We do this test, we do this biomarker, and it is a confirmed case of heat stroke. You rule out other things, then heat stroke is ruled in. That is how you do it. So spinal fluid analysis, because TB meningitis, even severe, more so pyogenic meningitis patient, same triad, not 40.5, but high fever, unconsciousness, and neurological signs. So you have to take a proper history in order to diagnose. But if other things are ruled out, if there is a heat wave, then make it with confidence. Don't shy away from diagnosing people. In CVS, we can have tachycardia, hypotension, cutaneous vasoconstriction, plus wide pulse pressure. There may be some non-specific STT changes. Now, this makes our life difficult. So how do we do it? We can compare it with older ECGs. If older ECG doesn't show, and there are non-specific ASTT changes means asymmetric inversion of T wave. It's a T wave, frank elevation of T wave, then it is a MI. But there are asymmetric inversion, prior ECG showing same kind or in a milder format, that it may be due to heat and heat alone. That is very important to note. And then there is one thing called as, which actually is very eye-opening thing, thermal cardiomyopathy. Heat in itself can cause a cardiomyopathy without following that MI route or the or the CVA route. So it in itself can cause extreme heat. Then we come to respiratory system. Respiratory, it can precipitate a non-cardiogenic pulmonary edema, or ARDS as we call it, basal Krebs, despite a patient is hypovolemic, but he's still having cramps. That is because of inflammation, not because of, and you should never give diuretics because it's not failure, it is inflammation. So heat can cause non-cardiogenic pulmonary edema. Then we have GI symptoms. This transaminasemia, hypertransaminasemia may be exceed more than 100 times normal, as I have discussed. Then we have coagulopathy. Actually, increased temperature destroys all the enzymes in our coagulation pathway. And besides that, there is a decrease in platelets also. So we have coagulopathy. People can bleed. We can have renal failure and electrolytes abnormalities like hyper or hyponatremia. I discussed in the section of heat exhaustion. So the fluid replacement has to be in accordance of whether it is hypernatremia or hyponatremia. So this is thing to take care of. Then we can have rhabdomyolysis and LDH and CPK. Increase LDH and CPK rise, not myoglobin. It is quickly metabolized, but LDH and CPK are raised. This can also be very, in absence of other causes, this can lead to this can help you in getting a diagnosis of heat stroke. But the problem with LDH is it is elevated in LDH is perhaps one of the most non-specific, where any tissue hypoxia, LDH increases. If you are reasonably confident that a person is young, athletic, no history of TB, nothing else to, I mean, cancer, how will it happen in a fit person? So LDH is high, he working in heat related, so it's fairly easy to make a diagnosis. CPK will also be raised. So we have two kind of heat strokes with different manifestation. Let us look at this table carefully. We have classic and exertional. As is self-evident, classic is in older patient, exertional will be in younger patients. And because classic happens in older patient, they are more likely to have a predisposing health factor or medications. Heat waves will more common in both. Both the heat wave is a causative factor in both. While as younger patient will be healthy. And younger people and older people, that is exertional versus classic. In exertional heat stroke, we have diphoresis. Skin will be wet to touch. Whereas in classic, we have dry skin. Exertional heat stroke, the basic the body is trying to compensate, but inadequately doing so. In classic, because there is no acclimatization, because the regulatory or the compensatory mechanism are knocked off due to drugs. So there is anhydrosis. There are a lot of these drugs have anticholinergic properties. Lot of drugs promotes cutaneous vasoconstriction. So there's the reflex mechanism to bear heat gets lost. So that give rise to classic heat stroke. Then renal failure may be in both. Lactic acidosis is more seen at a higher level in exertional. And then we can have rhabdomyolysis. Electrolyte imbalances and hypoglycemia. Electrolyte imbalances meaning thereby all three, sodium, potassium, and calcium, are more commonly seen in exertional type. So the basic pathophysiology is thermosensitive enzymes become non-functional. As a result, the production of heat shock protein increases and there is a cytokine mediated surge. And if cooling is delayed, this can lead to hepatic dysfunction or renal failure or DIC or multiple organ failure. So we have a lot of lab investigations, which is hemogram, basic serum electrolytes. I have discussed all these in details while covering the individual heat-related illnesses. KFTs, urine analysis, creatine kinase, ALFT, coagulation studies, atrial blood gas analysis, and lactate levels. These basically help us in ruling out other causes. We can also have ECG, chest X-ray, and CT scans. ECG may show tachyarrhythmias in case of heat stroke itself, only heats because only of heat stroke. Most of these respond by cooling a person, doesn't need to carry out any specific anti-arrhythmics. And then chest X-ray If there is a basal collapse coming, there's a non-cardiogenic, how will you differentiate? So if you do a chest X-ray, you will come to know whether it is an old problem, is pneumonia or some kind of fibrosis lying, or there is a acute problem. CT scan holds good in a similar manner. It rules out certain things like intracranial bleed or some other condition. Now, pre-hospital care, very, very important. As soon as we encounter a patient of heat stroke, the first and the foremost, which can be done by anyone in a resource constrained setting also, immediately remove the patient from environment. Like the important corollary is in CPR, when we do CPR, there is a very big bearing of time taken to initiate the CPR. You may be doing it too early, but it initiated quickly and shock the patient. If you have access to the handles, I am deviating from a topic a bit, but I want to apply the same corollary to this situation. So the earlier you shock, the better the survival. Hundreds of studies have proven. So the same adage holds good here also. So we have to act fast. Don't chase that elusive goal of ideal situation. Acting fast saves life. So immediately patient must be removed from the environment. Cooling should be initiated. For how do you do cooling? Simple, easy to do, cost effective. How do you do it? You take out all the clothes, replace wet towels or sheets, and spray water on the patient and start fanning him or her. Electric fan good. If you don't have electric fan, start doing with a new. Start early. If you don't have access to 15-degree water, which I will tell you, do it with plain water, tip it. But start. Meanwhile, ice packs will come, everything will happen. But you start early. And when the patient is being transported to the closest hospital, make sure that either you do in between these things or at least you switch on the AC full blast if a vehicle is equipped with AC. So this is a slide from management in a primary healthcare. This is more or less the same thing. Suspected case, call 108. Bring victim to safe, cool and shady environment. Take vital signs. One very important thing. If you have besides cooling, then what will you do? If you bring the patient in ambulance, provide him or her oxygen supplementation as soon as possible. As soon as possible. Because heat stroke is a condition of overwhelming majority of heat stroke have tissue level hypoxia because there is a circulatory imbalance. So oxygen supplementation, suppose you don't know whether he is heat stroke or snake bite or CVA, then also oxygen supplementation will do no harm. So oxygen supplementation is very, very important. And besides this, remove unnecessary clothing, start tepid sponging, increased airflow by using a mist fan or spraying of cold water all over the body. Apply cold compresses, ice packs in neck, axilla, groin, and head. Same as we do in fever also. If possible, start IV drip of cold saline. Now, this is a very sensitive thing. So it should not be very, very cold, but you can start a relatively colder saline. And the infusion rate has to be adjusted. External cooling is actually placed more emphasis upon, but it is not so unsafe. And why do we say that? Because when we give FFP to a patient, fresh frozen plasma, we give it absolutely in freezing condition. Thawed and started infusion, full speed. So, but very high amount of very cold solution should be very cautiously, given. Then we have vital signs monitoring. This is something which now in a higher center, if we have now brought the patient to equipped center. Now, what is the classic line of management? If you have all the resources available, then it is divided into 3 sub-segments. One is acute management. How do you treat patient acute? Then heat stroke, nearly all of them will have some kind of complication or another. How do we treat this complication? And third, how will we the disposition and follow-up? How many we discharge or dispose of the patient and follow him up or her up? So acute management comprises of 2 things. One is initial resuscitation and cooling strategy. Now, if you the patient that cooling early, taking him away from the heat was in a situation when we did not have access to resuscitative measure. We were not in that time in full-fledged medical center. But if we have access to a full-fledged state-of-the-art place, a medical college or a district level hospital, then even before the cooling is ET, endotracheal intubation, we should do, and we should do a continuous core temperature monitoring. Put the patient on high supplemental oxygen, and peripheral method to measure temperature are not reliable in case because skin there is a vasoconstriction, so very difficult to measure. And then hypoglycemia is very frequent. Even in diabetics having heat stroke, they will have hypoglycemia. And if you are unable to say, this is a big center, we have now reached a big center and we will have access to it. But I am telling you we run a diabetic clinic in RML hospital. Hyperglycemia, hyper is harmful, but hypoglycemia is lethal. If I have to choose between harmful and lethal, it is better to choose harmful. So, and even if suppose a patient is, you don't know his or her sugar and you give him sugar, IV infusion, the maximum damage you will do is some kind of ketosis that can be managed. But if a hypoglycemic person doesn't receive sugar in time, the consequences are deadly or a vegetative state prolonged. We tell it in great detail to our residents also. So we have to hypoglycemia, you measure it, very frequent finding, and give glucose infusion. Unable to measure, then also one glucose infusion can be given. And then second, since peripheral vasoconstriction delays heat dissipation, repeated administration of discrete bolus of isotonic crystalloid for hypotension is preferable. Preferable to what? Preferable to administration of, the meaning of this line is, whenever a person of hypotension and shocks comes to us, what do? We do only two things. Either we give him fluids or we start the person on dopamine, dobutamine, noradrenaline. So we should refrain from that. They also have a role. I will discuss them later on. But initially, you should start with isotonic crystalloid solution. Colloid have not a role to play. So crystalloid you start giving. Now, what are the various cooling strategies? This is the mainstay of treatment. So first is, the ideal technique is to spray cool water at 15 degrees centigrade on the exposed skin, and while the fan direct continuous airflow on the moistened skin. And then in addition to this, we can apply cold packs to the neck, axilla, groin. And cardiac electrodes can be placed for continuous monitoring, because a lot of patients can have tachyarrhythmias. These spontaneously vanish, but in some cases they can lead to some catastrophic consequences. So cardiac monitoring is must. One of the other cooling strategy is immersive cooling. Immersive cooling is we just immerse a person in cooling. This is a good technique and a bad technique. There are pros and cons. Initially, what happens is, when we immerse a person in cold water, it is a bit difficult logistically to do. But even if we immerse a person in cold water, so initially there is a peripheral vasoconstriction in skin. So the heat loss, rather than increasing, decreases. The heat exchange between the surrounding and the water, because there is a reflex vasoconstriction. But after that initial gap, this is also a very good cooling technique. Then there is a very rapid transfer which happens between the coolant and the subject. But these techniques present a very significant monitoring and resuscitation challenge. Suppose you have to place an ECG electrode. Then where will you put? Very difficult. Immersed patient में तो electrode लगाना बड़ा मुश्किल है. And then where is it best for? The young athlete, military personnel. Then you can use it. And like earlier also I said, all the active cooling measures should be stopped at around 102 degrees Fahrenheit, because there is an after cooling also. Less or more with every method. So we should stop there. And then there are some not so important or not so used things. One is cooling blanket. The cooling rate is too low, so you should not. I don't know whether, see, I have seen heating blankets, but sir, Dr. Shrivastava, have you seen cooling blankets? I want to just know from cooling blankets. I just came across in textbook. Sir, बताइए cooling होते हैं क्या कुछ? मतलब मैंने तो
I have no
in
idea.
India. So heating blankets I have seen. So cooling blanket rate of cooling is very low. So but this is actually textbook knowledge which I am imparting.
So I just
Then
wish
we
to
have
add,
some.
Dr. Ajay. Yeah,
Yeah,
hi,
yeah,
this
please
is
go
Dr.
ahead.
Ankit here. Yeah, hi. So we are having, we use this whole body cooling mechanisms, which are being used in the case of the babies who are suffering from perinatal asphyxia or birth asphyxia. Yeah.
Okay.
So we use them in that of the newborns. Yeah. So they are there. Yeah.
Okay. So they're nice to know. Dr. Ankit is a pediatrician from All India Institute. So thank you so much for that pearl of wisdom. So we have something called as cold irrigation of bladder or GI tract, and then we can do lavages also. Peritoneal lavage we have done a lot in residency for our renal patients. But cold water lavage is an invasive phenomena. As a last ditch effort, we should use it, but not usually. All these aforesaid measures which I mentioned are good enough. Then we have an extreme measure in form of cardiopulmonary bypass, which is another very labor-intensive method. So what are the complications? We now come to the penultimate segment, which is complication management. We can have in our patient coagulopathies because of destroyed enzymes because of heat injury. So these are managed by fresh frozen plasma or platelets. Seizure can occur in a heat stroke. So besides therapeutic cooling, what do we do extra if it is not if a person is not getting controlled by therapeutic cooling alone? Then we should start treatment with short-acting benzodiazepine, namely lorazepam and midazolam, in the doses 0.1 milligram per kg body weight and 0.2 milligram per kg body weight bolus, followed by an infusion of 0.2 to 0.6 milligram per kg per hour. Now, this line is important. Next one, the barbiturates, and there are two other things in our medical emergency. First, we give benzodiazepine. There is a protocol. Then we give phenytoin. Then we give barbiturate. Nothing happening in normal seizure. Then we paralyze the patient and intubate him or her. But in this is a unique thing because we have to give benzodiazepine infusion. Phenytoin is not very effective in controlling the seizures of heat stroke. It is not very effective. And barbiturates can be used actually, but if there is no other method, because they impair sweat production. So barbiturate, we should be wary of using barbiturates in a case of seizure secondary to heat stroke. So they are not very effective. And benzodiazepine, meanwhile, have one important function. Usually the patient is agitated in clinical scenario. Or a lot of time, these patients are very agitated. It calms them down also. So aspiration is also in respiratory complications. We have aspiration and pneumonitis. We can also have pulmonary hemorrhage, edema, ARDS frequently, and they have to be managed in accordance to the guidelines. Dyselectrolytemia and hypoglycemia I have already explained. Now, there are some cardiovascular complications, namely hypotension, which there is one unique thing actually. There is a dehydration and there is actually a high output cardiac failure in some patient in heat stroke because peripheral vasodilatation and then there is a stroke volume increase. So you can have a unique situation where CVP is elevated, still the patient is in high output cardiac failure. So in that cases, we can use very selectively after adequate fluid resuscitation, dopamine or dobutamine, if we are sure of these two. Then we have rhabdomyolysis and acute kidney injury. This is more common in exercise-induced heat stroke, and the most common finding being oliguria. And we can, as I mentioned earlier, while enumerating the differences between classic and exertional, electrolyte imbalances are more commonly seen in exertional. We also can have a GI bleeding or ischemic injury. So how do we dispose these patients of and how do we follow them up? So most of the patients with minor heat emergency syndrome, namely heat edema, syncope, heat cramps, require only stabilization and treatment with outpatient follow-up. But in case of heat exhaustion with predisposing factors and comorbidity, we can prolong our observation or we can admit the patient for 1 to 2 days in a hospital in heat exhaustion. And in heat stroke, all patients require admission, monitored, and very intensive, high intensive care. And if a patient's initial core temperature is beyond 42 degrees, so and it is the exposure is for a prolonged period, then it is the prognosis becomes poor. So the monitoring has to be intense. And the number of dysfunctional organ systems, if you have hypertransaminasemia along with renal failure, bad kidneys, 2-3 other systems involved, then the prognosis becomes poor and there's a high mortality rate. As it is, mortality is between 30 to 80%, as I mentioned before. Now, this is the last section of our presentation. How do we go about investigating a case of HRI death due to HRIs? And for all HRI death only occurs because of heat stroke. So it is basically an investigation of heat stroke. And how do we collect data? So there it is divided into sections A to G. And A is very simple. This is the identify mechanism. So name, gender of the patient, sex, age, mother's name, district, state, and then socioeconomic status, and the last occupation. Two things to note are, insofar as possible, it is better to fill these columns up from a valid government ID. If you don't have, then obviously the information can be acquired from an attendant too. And then the A7 is last occupation of the disease. How do we define? So last occupation is what was the occupation since a week of a person's death. 1 week. एक हफ्ते पहले क्या कर रहा था? एक हफ्ते पहले, है ना? But that is defined. Now, section A is disease identified details. Section B is a place where actually the patient was found. My screen is, how do I, just a second. So it, just a second, I require some kind of technical support at that top level. Rita, ये इसे So back to business. I am unable to read the top part of my slides. So this is about actually, so this is the section B. Hey, hold on. Backspace camera. Slide has come to halt. Just a second. Okay. Okay. So where was the, now we come to the geography. Where was the location? Okay. A was the identification. Second is the location. And was the disease found unconscious or dead? And if he was found unconscious, then what was the location? The reason for this is that the purpose of getting this information is that when the decedent is found dead, it is important to know the circumstances in this patient death and then correlate it with the weather data of that particular area. Now we have section C, in which we have basically a clinical section, and preferably this section should be taken from the medical records. So symptom, skin condition, was the patient in altered mentoring, core body temperature, pulse rate, rest, is simple to fill up. All these are very simple things to fill up from a hospital records. And then C5, look at C.5 carefully. Did the deceased have an alcoholic beverage within a day or two of illness? So while mentioning common drugs, which are beta blocker, calcium channel blockers, diuretics, and then I mentioned substance of abuse, in which I mentioned ethanol as last, but not the least. So this is a very, ethanol takes away our ability to cope with heat. So that is very important history to take. Section C, how do we fill it? Preferably from medical records. And if we don't have them, then respondents. And symptom of time of illness gives us a great knowledge about diagnosis. Then date of time and place is for correlating the climate variables. And then we have alcohol consumption to as a exacerbating factor. Then we have surrounding. This section is section D. This section. Just a second. Scroll down हो नहीं रहा, इससे देख लेता हूँ.
Are they able to see?
They are able to see, but no problem. Now it is open. So this is okay. Section C, okay. Now we come to section D. Section D is about outdoor activities just before the onset of illness. So that is very relevant, and as could be, seen by that what was the patient doing just before the death. And especially pertinent to know is D4, which is, was he working during peak hours of the day, 11 to 4? And then was he working in some heat source? And if the heat source, you have to identify that heat source, because they have a bearing, hot furnace, whether it was cold or steam, cold heat or a wet heat. I mean, dry heat or a wet heat. And was the disease doing any physical exertional activity? So was he sitting in a vehicle? So these are basically the condition, outdoor conditions. After outdoor conditions, we come to the section of indoor. And indoor, what was the situation like in indoor conditions? So this is a pretty self-explanatory form. Was there coolers? Were there coolers in his room? AC? And then which type of room was he in? Pakka house, kacha house, are there sufficient ventilation form of windows, E5, E6? They're very simple questionnaire to fill. And then last, this is a section medical comorbidities. Section F is about comorbidities. Then medications, illnesses, concurrent illnesses. This section talks about that we have to fill it up. Then last, about weather conditions. What was the maximum temperature? Maximum temperature in past 3 days. Is there a heat wave affecting the area? Relative humidity. So it has all the questions. And who can fill this form is any medical officer of PHC or CHC, doctor on duty in a health facility or hospital where the suspected case of HRA died, or an epidemiologist doing death investigation. After the form is filled up, write the name legibly along with designation and signature and date. So with this, we come to the end of our presentation. Thank you very much for then we take home messages as we summarize it up by that early confirmation of heat-related illness and initiating resuscitation ASAP is very important. Cool first and transport second should be followed. Rapid cooling is critical, and morbidity and mortality is directly related to the duration of core temperature elevation. So we should try to cool the person as soon as possible, and close monitoring of vital parameters and early identification of complications is an important step in preventing mortality. So I thank you all for a patient listening, and questions if are very welcome.
Thank you, Professor Ajay Chauhan. It was a very enlightening lecture, and I think most of the trainers here who have participated, we had over 500 of them participating today from the India, and I think they must have really understood a lot of concepts related to the physiology, pathophysiology, predisposing factors, the diagnostics, the differential diagnostics, especially the focus on heat stroke that you provided, especially the management component, how cooling is so important, how much role it plays, and also how classical and exertional heat strokes are different, how the lab finding, management techniques, and then the death investigations. So all those detailed concepts that you have placed before this audience. Thank you very much for this. It's a very large audience. I don't know how much questions will be available. A few of them are available on the question answer box, and I'll try to see if you can find an answer to a few of them. Uh, the first one I see is hypothermia, hyperpyrexia concept is clear, but in clinical presentation at OPD, how will I differentiate between a hypothermia and a hyperpyrexia condition?
Very easy. Take history. If a person is more likely to, history is very important. Person has come from a surrounding which is, which is going towards a diagnosis of heat-related illness, exertional activity, a laborer, then it is. But hyperthermia and hyperpyrexia cool a person. If a person is responding and then again not again developing fever, once the cooling is done, then goes more in favor of hyperthermia.
Yeah.
So, and improvement in symptoms after cooling, that happens in hyperpyrexia also. But again, it will, if there is an infection process going on, after cooling, it will again, but such will not happen with, so that is, and history will give you 80%.
Thank you. So before we go on, I request all the audience to continue to stay back because the next speaker is already available with us, and instead of starting at 2, we will be shifting on to him after the question and answer session is there. So please do not log off. Please do not log off. Stay with us for the second session. We'll be starting it immediately. The next question that we have here is that he wanted to understand the role of pupillary reaction in heat stroke.
Pupillary reaction depends what condition has a person comes in. Pupillary reaction, actually, it is a very important sign in ruling out other conditions. In hypothalamic fevers, in poisoning, barbiturate poisoning, if the person is having a sluggish pupillary reaction, or in a person with having pontine bleed can have very small fixed pupil, and he can have hypothalamic fever also. That is more common in ruling out other condition than ruling in. And one more thing, just is similarly as a pupillary reaction. If a person is, suppose, if he or she is having a snake bite, then besides pupillary reaction, we can see gag reflex also. If the gag reflex is also lost, if a person found abundant in a jungle, hot, came to us, so a gag reflex is no response on cooling, pupillary reaction sluggish, gag, the more common other causes, more goes in favor of that is.
Thank you. And then another next question I can think is, he wants to understand how does coagulopathy happens in heat stroke?
Because the mechanism to control body, we are all warm-blooded animals. We are all warm-blooded animals. In order to survive, our body need to operate within a definitive temperature range. If the temperature range is surpassed, as happens in hyperthermia, as I gave a lot of time in hyperthermia versus hyperpyrexia. In hyperthermia, hypothalamus functions, it's not the set point which is raised, or it is not an adaptive mechanism. It is the loss of all adaptation. So there is no limit to which body temperature can rise. It can go very high, beyond our range in which our enzyme functions. So coagulopathy happens when all the enzymes are knocked off, because all the protein gets denatured at higher temperatures. They lose their functioning. So that is how coagulopathy happens.
Thank you. One more question here is, what is the choice of the first IV fluid to be given?
Depends, but if you ask me, DNS is a very safe fluid to use, dextrose and normosaline. It will give both, to preferably initial, but then obviously you have to tailor it.
Yes, thank you. There is a question by Dr. Dolly Singla. I don't really understand it, but I'll just read it out.
Sir, in heat stroke and toxicology vignette, don't you understand? So thanks, Dr. Dolly Singla. It's a very good question, and it's a real life actually thing. But a lot of times, despite extensive search, we are unable to find fang marks. And it is not only snakes who bite, there are scorpion bites also, which are very small. And we have encountered 2-3 such cases also. So not all the cases are. So fang mark, if it is visualized, well and good. If it is not, then very difficult. So it is a toxic. That is the answer.
Okay, right. The next question he is asking is heat stroke also common in areas of high altitude and in cold areas?
See if earlier it was in 19 states. Now it is in 23 states. Sir will, I think, correlate it with better.
Right. Sure. Yes.
And it is in, I read the name of states carefully. It is in Jammu Kashmir also. Do you
Right.
agree, sir? Because you are the boss of this whole program.
Yes.
It is
And,
in
yeah.
J&K also.
And
So
one
it is
one thing that I think you also highlighted in your slide in the beginning, the heat waves are dependent on different temperatures for different areas. The minimum requirement for heat waves in plains may be at 40 plus, but for hilly
yes,
areas that is 30 plus.
30,
So
30
any
plus.
deviation that is 30 degrees Celsius and deviated to 4.5 from normal temperature would be a heat wave condition in a hill state.
Yes, absolutely.
And then you have a question is that what are the possible complications of rapidly cooling body temperature?
In a case of heat stroke, we have to bring it down to 102 degree. We don't cool beyond that because there is some after cooling effect also. And we should do it in as short as possible time as possible. So that is we will not obviously go beyond 102. So there won't be any complication if you monitor patient carefully. But if you ask question as a matter of theory, then obviously if you cool a person below normal, there will be hit heart can stop in hypothermic condition. If you take although the discussion is about heat related illnesses, if a person drowns in a cold water lake and is rapidly cooled, then otherwise, if you asking in heat related illness, you have to preferably cool the body and bring it down to 102 and then stop it.
Then there is a question I think you already answered about the IV fluid. You said DNS is probably the safest one to go. And then there is a last question I can see is what is the role of antipyretics in hypothermia?
I think all of you should answer that question. I devoted too much of time and energy.
Yes,
antipyretics have no role, none whatsoever in hyperthermia. They have role in fever, and that is, I think I devoted a significant amount of time.
Yes, significant, right, you very role. So with that, I think we have taken care of all the questions that were provided in the question answer box. And thank you once again, Professor Ajay Chauhan, for being with us and providing your time and your resources to this important session. And special thanks for you being with us as one of our members. Yes, please.
Sorry to disturb, sir. I have two things to ask Dr. Ajay. Would be here.
Dr.
Ajay, so you very well highlighted that the sequence of diagnosis or differential diagnosis should be cooling first in the circumstances where you expect there is a heat wave outside. So because I have seen that sometimes people wait to exclude other things and then they cool. So so what are the things that like criteria they should
cooling first? Immediately. See, cooling first is important. See, let us assume for argument's sake that a person is suffering from fever and not hyperthermia. Okay, for argument's sake. Even that, evaporating cooling is a recommended solution for fever. So there is no harm in cooling. So you should not wait for cooling. See, after a proper history, circumstances, a person should be able to diagnose hyperthermia. But even if he or she is doubtful in a setting, cooling is not going to do any harm.
Right. Okay.
What do we do when our patient gets, don't we do cold sponging in fever? We do it in fever also. So it is not going to harm anyone. You can avoid aggressive maneuvers like immersive cooling till a later, but evaporate the basic thing, spraying him or her with water, opening clothes, and then fan, blowing air through fan. These are very simple measures which are not going to harm. Putting ice packs in axilla, which is common across the spectrum of both fever as well as the hypothermia. So they are not going to harm. We should initiate them as early.
Okay, sir. Next question I had is, what is the role of cardiac enzymes and CPK levels in confirming a heat stroke? Do they have a role? Because if we are
No,
going to
these
wait
are
for
actually, yeah, good question. These are all ruling out things. CPK will be higher in this. Creatine kinase is higher, as I discussed in my webinar also. But now there are non-specific STT changes. So there are, in lot of times it is very, very difficult, because again, in the spectrum of heat related illness, heat stroke can also precipitate a MI. So there are a lot of things which doesn't have a black and white answer. You have to compare the ECGs as a previous ECG. If a person is already having, suppose there is a history of a myocardial infection 2 years back, and then he is having, the presentation is only chest pain, then it is going more in favor of, you have to make a diagnosis in its entirety. There is no magic potion which will, give you a very clear, but there are non-specific STT changes as well as CK elevation in heat stroke, and heat stroke is known to precipitate MI by 10 folds.
Right. Okay. Thank you very much, sir. I just wanted to highlight some points here from public health aspects, because we also discussed death form. So I just want to inform the participants that this form should be filled by medical officers and epidemiologists. And in this form, we are using suspected heat stroke death. So we might not know what is the exposure of heat in these cases. So we have indoor heat exposure and other things that we are including in this. Besides this, in our surveillance, we are also asking people to enter emergency admissions and all the deaths in the hospital facility, because as sir also mentioned, we also have increased cardiovascular respiratory death in times of extreme heat. So we are trying to capture all of these on the heat stroke. So all of you should know that is also a part of surveillance, and it is an essential information for us to understand how actually heat affects our population. So that is what I wanted to convey.
Actually, Dr. Purvi, what you are saying is, now I just will take 30 more seconds. I will not, because see, this is a part which Dr. Shrivastava will correlate. We discussed a great deal. Dr. Gurtu was also there, professor of medicine from LHMC. It is very, very difficult to sieve out that whether this condition, very difficult. And then it can only be done by complex, biostatistical methods. You have to compare the data from the previous year and then correlate with the temperature rise. Then we can come at some figure. How will a person absolutely corroborate that it is very, it requires,
That's true.
Great bio research methods, biostatistical models.
Okay, so we wind up this session of the morning, and we start on with the next session for the pediatricians. So thank you again, Professor Ajay Chauhan, for being with us. And now I would like to call Professor Ankit Verma. Please, can you switch your camera on for the audience? Yes, Professor Verma. Yes. Professor Ankit Verma, are you there? Okay, thank you for being with us. And so once again, a brief introduction for this. We are now here at the National Program on Climate Change and Human Health, and we have around 500 professional joining, program officers and clinicians from various parts of the country. And our objective today was to do a virtual training of master trainers on the clinical aspects of heat-related illness. And in the morning session, we had a discussion about how to handle adult patients. Now the session is about the pediatric patients, and Professor Ankit Verma is a faculty in the Department of Pediatrics at All India Institute of Medical Sciences at New Delhi. He's also been a very enthusiastic member of the committee that we had formed to formulate the manual that you have, all of you have, and the link has been shared on heat and health. And he helped in the designing of the clinical protocol for the pediatric section. I assume that all of you will benefit with this discussion with him. He will be touching upon specific issues related to pediatric population in heat and health. So over to you, Professor Ankit Verma. I request you to take it over. Thank you.
Yeah, thank you, Aakash sir. Yeah, I just wish to share my screen, sir.
Yes.
Yeah.
I need to give you the.
Right.
I'm giving you the co-host. Okay, now you are a co-host. You could share your slides. I'll request Professor Chauhan to take off his slides. Professor Chauhan, can you take off your slides, please? Yes, thank you.
करो तुम मुझे
So, yeah, Aakash sir, hi. So can you
yes,
see
we can see your slide. Yes.
Yeah, it's heat-related illness in children, sir. Yeah. So are the slides moving, sir?
Yes, yes.
Okay, fine. So yeah, good afternoon, everyone. I shall be briefly touching upon that of the heat-related illnesses in that of the children. A lot of things has been said in detail by Dr. Ajay sir, and sir have covered the things in quite detail. I will try to avoid the same repetition of the things, and will try to present the specific things which are pertain to that of the pediatric age group. So this is the brief outline I shall be touching upon, the case scenarios, introduction, risk factors, and then the definitions, which I guess we have already gone through, the clinical workflow, the first aid informations, and the sports activity guidelines, and briefly I shall be summarizing at that end. So this is how typically a child with that of the heat stroke they present. So this is a case one. So we find that a 12-year-old boy, who's a schoolboy, who is playing basketball on a hot July day, and the child felt unconscious and sort of agitated and confused. The sports teacher, he had checked the temperature of the boy, and it came out to be 105.5. So the coach, he bring him to that of the emergency room of the hospital. So on reaching the hospital, we took the vitals of the child. We found that the respiratory rate of the child was around 38. That means there was a tachypnea. The heart rate was around 120 beats per minute. And the blood pressure, when we had recorded, it was around 88 by 54, and the peripheral pulses, they were feeble. So that's how the typically a patient with that of the heat stroke will present in case of a pediatric age group. So another common presentation, what we see is that for small children. So basically a bystander, he discovers that a 2-year-old infant is in the back seat of a car in the month of August. On cross examination, on when we look, the child is found to be flushed, fussy, and had vomited. So the child has been brought to that of the emergency department for further management. We took the vitals of the child and find again that there was a tachypnea, tachycardia, but this time there was no hypotension in this child. So these are the most common two presentations. That's how the children and the infants, they present out. So with increase in the global warming, the incidence of the heat-related injuries has increased. And it has been nearly seen that 50% of the total adult population, the children, almost half or the 50% of the children, they comprise of the victims of the heat-related injuries. So that heat-related injuries, they typically occurs in that of the majorly two age groups in that of the pediatric age group, that is in exercising adolescents and the children who are left unattended in that of the vehicles or in that of the excessively warm environment, as we had seen in this we had seen in the case scenarios over there. So our aim is that we have to counsel the caregivers in recognizing the danger signs which are related to the heat exposure and preventing the dehydration and heat related injuries. And when prevention fails, we need to promptly recognize and treat the heat related injuries, which becomes a paramount. So what is different in case of a child, which is not there in case of an adult? Why the children, say, are said to be more vulnerable as compared to that of the adult? So this is because it is seen that the children's body surface area, it's greater as compared to that of the adults. Secondly, it has been seen that they produce more metabolic heats per kg body weight. Then the rate of sweating, which is a major way of losing the heat, is quite slower in the children as compared to that of the adults. And the temperature when sweating starts is quite higher. So the child, they can basically tolerate to a more range of the temperature, and their tolerance rate is also higher. And when the sweating, which is the major mechanism of the heat loss, that is also higher. The temperature set point is again higher. Okay, and then it has been seen that the lower cardiac output at a given metabolic rate is there in case of a children as compared to that of an adults. Then another thing, the rate of acclimatization is slower in case of a children. However, the adults, they acclimatize quite easily. And another thing which is more leads to the more heat related injury is that their children, they do not tell, and their thirst response is blunted as compared to that of the adults. And the hypohydration, that means less amount of the volume, it affects the children more than that of the adults. So these are the major risk factors why the children, they are seen to have more heat related injuries as compared to that of the adults. Now this is a list of the conditions, which are the medical conditions which predispose to the heat illnesses. Okay, so if the child is already having some fever, he's sick, suppose he is having acute gastroenteritis, okay, or he is a case of diabetes mellitus or insipidus, that child is more vulnerable for heat related injuries. Okay, then there are certain conditions in the children per se in which there is a suboptimal sweating, like if the child is obese, or if the child is a case of a spina bifida, or the child has a cystic fibrosis, or there is a sweating insufficiency syndrome. Then there are conditions in which excessive sweating is there. Excessive sweating will be there. We know that the basal metabolic rate is quite high in certain conditions like congenital heart defects and hyperthyroidism. So that leads to excessive sweating, and which further precipitates the heat-related illnesses in the children. Then there may be certain children who will not at all tell that we are thirsty, we are feeling thirsty. These are the kids who are with the special needs, and the children with the who are quite of a younger age group. They won't tell. Suppose a child is there in a foundation or in nursery, he won't be able to, and the school teachers is saying, okay, let's go out and play on the swings and the slides, but they won't be telling you, okay, ma'am, we are thirsty. So it should be a good practice by a teacher or whosoever is the caregiver at that point. So they should ask at least have some sips of water, to especially that of the younger children, so that they get a good water reserve before going out into that of the sun directly. Okay. Then there are psychiatric illnesses like anorexia nervosa, and a previous episode of heat illness, which leads to hypothalamic dysfunction. So that further predisposes a child with that of the heat-related illness. Now, I shall be touching about that of the pathophysiology of that of the heat illness. So I guess this thing we know from the day of our physics, the 4 basic mechanisms by the heat dissipation it occurs. It's the convection. That means the air flows from a surface to another. The second is the radiation. That means the radiation of the body heat into an environment may occur if the ambient temperature is below that of the body temperature. Okay. Suppose I'm sitting right now in an AC room. So the major mechanism of my heat loss right now would be the radiation. Then another is the conduction. That is the heat moves from that of the warmer to that of the cooler surface, and heat vaporization. So heat vaporization, it basically means that cooling through that of the environment at the skin surface. So sweat evaporation is the main mechanism of the heat dissipation in the environment, warmer than that of the body temperature, as other mechanisms are much less effective under that condition. So what happens that the body loses the above, the body uses the above mechanism of the heat dissipation to balance out the effect of heat production, which can increase 10 to 20 times higher when a person do the exercise. So as the core temperature of the person, it starts to rises, the at least thermoregulatory mechanism, they shift from heat storage to that of the heat dissipation. That means rather than conserving the heat, the person will try to lose out the heat at that moment. And the core body temperature is regulated through that of the anterior hypothalamic nuclei. This we know that. So what happens when there is an increase in that of the core temperature, that means the core temperature, core body temperature, it causes peripheral vasodilation. Okay. And with increase, so there is a peripheral vasodilation. Okay. So the body heart, what it will do, it will try to maintain the cardiac output. So what it will do, it will try to increase the heart rate. There will be tachycardia, and there will be increase in that of the stroke volume. So we see that rise in the 1 degree centigrade in that of the core temperature, it increases the cardiac output approximately to that of the 3 liters per minute. So what happens with time, the total peripheral resistance, it decreases secondary to that of the vasodilation. And you know, all these mechanisms, they drive the warmer body blood away from that of the core to that of the peripheral circulation, where it can reach the skin and allow the sweat vaporization to occur. Okay, so this is the normal mechanism by which the body, it loses the heat. But what happens if the body cannot increase the cardiac output? When the vasodilation occurs, then there occurs, rather than vasodilation, there occurs a vasoconstriction, which develops to preserve the central perfusion and that of the blood pressure. And this results in that of the impairment of the heat dissipation, and the body is unable to move the blood from that of the core to that of the peripheral circulation effectively. So that's why the temperature of the child or a person, it continuously increases, and that further leads to that of the heat related injuries. So this is a basic pathophysiology why this heat related injuries they occur, and that's a mechanism which has been proposed in that of the pediatric age group. Now you have got a link, and that is having this manual with you, in which we have classified the heat related illnesses into the basically 7 or 8 types. These are the various, so it's basically a spectrum. So it's not that key in case of a children you will see only a heat rash, or you will see only the heat stroke. So depending upon that of the severity, kitna severe usko, how much severe is the exposure to that of the heat, and what is the functional reserve of that child, and how much the child had already acclimatized. Depending upon all those factors, the spectrum will differ of that of the illnesses. So let's go one by one to these things. So first is that of the heat rash, prickly heat, or malaria. So this things we had commonly seen that. So so you must have seen this thing. Hindi mein jaise what we say that pit is commonly said in the word is in that of the Hindi. So the infants, so you can see in this photograph over here. So you can see there are the tiny pustule-like things, and these are the erythematous papular or vesicular rash, which they happen because there is the obstruction of the eccrine sweat glands, and they are usually it's quite itchy, and it's benign, and it usually limits by itself. Nothing much needs to be done over here. The treatment is supportive, and the thing it is more like more that of a preventive thing. The child should not wear the child should wear the light clothes and should wear the loose garments, and should basically avoid that of the overheating. Now, the next thing is that of the heat edema. Heat edema, it's not commonly seen in that of the children. So edema, you can see here in this picture, the feet of the child, they appears to be swollen. Okay. So they may happen on the hands, feet, or other dependent parts of the body, and they occurs in the unacclimatized individual as a result of vasodilation and the venous pooling. So venous pooling will be there. So that's why the edema they occur. And it is more seen in that of the elderly age group, but however, it can also be seen in that of the children. And the treatment is usually supportive. So basically what we need to do, we have to elevate the limb. So if the feet of the child are swollen, we need to just simply elevate by putting some pillow or any other thing below that of the feet. And beside that, if it's so severe, the child might also need the compression stockings. So you must have seen the compression stockings that's also used in the treatment of the varicose vein. And the another thing is that we have to move the child to that of the cooler environment, so that the thing, so whatsoever harm has happened, and now it does not increase further. Next thing, which is also seen in the pediatric age group, that is heat cramps. So heat cramps are basically the involuntary contraction of the skeletal muscle that occurs during or after the exercise. So it's basically a group of the muscles. So suppose cramp, you know that sometimes there is, so for example, there occurs a cramp that after pulling up of that of the hamstrings. Okay, so it's the same thing. So basically all the skeletal muscles which are involved in the exercise, they may get involuntary contractions. So it occurs in the dehydrated, deconditioned, and poorly acclimatized athletes. So one thing interesting to note is that it's not necessary that heat cramps will happen only in the warm weather only. Suppose we see these heat cramps also in the swimmers. Okay, so sometimes the boy come or we see commonly while swimming itself, during swimming itself, because what happens, suppose I'm not acclimatized, I've not practiced much, and I've done a lot of exertion, then what happens, there may occur the cramps in that of the my legs, or somewhere else they may happen. So it may also happen during that of the cold environment also. So but the thing which is more important is that if I'm dehydrated, I'm deconditioned and not acclimatized to that particular condition, so those cramps may occur. Then again, the treatment is basically the supportive. That means I need to say to that of the athlete that you need to take rest right now. You need to stay hydrated. Okay, so hydrated with water, and preferably we should take something commonly which is having some salt solution. The most common thing which is available is a shikanji or something like that, or they can take some there are the things like like retrograde, which are having electrolytes, and or the simple ORS that can also be taken, and the hydration is the mainstay for the treatment of the heat cramps at that moment. And static stretching, it should be done at that moment. Okay, so not the dynamic stretching, just stay at rest and do slight stretch in the sitting position only. Now, the next common thing which is more seen in case of a children is the heat tetany. So heat stress, that is, it may cause per se hyperventilation. So how the baby present, how the children they present, they basically come from they will give a history that they are there exposed in the warm environment, or doing they were playing in the playground, or doing some exercise. Okay, and suddenly they complain that they are having circumoral paresthesia. They will complain that there is some tingling which is occurring around our mouth. Okay, and beside that they start hyperventilating. Okay, they will take deep breaths. They will have this chain stroke type of the breathing. Okay, so these things, that's how they present, the children they present. Okay, and in long run with hyperventilation, there may occur the respiratory alkalosis. If I check that of the chopstick sign, and it will come out to be that of the positive. Okay, and the treatment of the heat tetany is that, first of all, that's a basic principle of the heat related injury. The first thing is that, foremost thing is that, as Aakash sir had also said, and Ajay sir had also said previously, that we need to move the patient to that of the cooler environment. We need to remove the source, which is a precipitating factor over there for that of the heat related injury. And occasionally, so if I remove that child and I just keep him in a calm environment, in a cooler environment, gradually the child who was hyperventilating, gradually he will subside down. Okay, and very rarely, occasionally, there may be the need of that of the oxygen, and if the oxygen needs to be given to those patients, it should be given with that of the oxygen mask, and the flow rate should be set below that of the 5 liters per minute. And if the child is too much agitated, it's too much hyperventilating, then we may use a start dose of benzodiazepine like midazolam and lorazepam. That might be used. And it's only to be used only in case where the child is quite irritable and is not calming down at all. Okay, so that's the treatment about that of the heat technique. Now, coming to another two things which we commonly see in that of the pediatric age group, I've just made a table to differentiate between those things. They are the heat exhaustion and that of the heat stroke. So actually, the thing is that heat exhaustion and the heat stroke, sometimes it becomes difficult to differentiate between these two things, heat exhaustion and that of the heat stroke. And the things, they may be overlapping each other, but the main thing is that I should start acting upon that of the patient at that very moment, so that the heat exhaustion, it does not turn into that of the heat stroke. So heat exhaustion is a first state. If the patient remains unattended, then and we have lost the golden period, or we have lost the window of opportunity of our action, then that patient goes into that of the heat stroke. Okay, so how I would differentiate between the two of these. Okay, so most common thing is that of the about that of the mental status. This thing I can even tell in that of the periphery. Suppose there is a child who I had told you about that of the first case. Okay, so you just let me go briefly back. So this was a baby, a 12-year-old schoolboy, who was playing basketball on a hot sunny day. His temperature was 105.5, and he's agitated and confused. Okay, so here I had seen that the child had developed hypotension. So if the hypotension had developed, then this child had gone into that of the heat stroke. Okay, so I should have acted much before the child had gone into that of the hypotension. So this is the case scenario 2. So that's how this is an example of that of the heat exhaustion. So this is a 2-year-old child who was there in that of the back seat and was flush, fussy, and had vomiting, and was brought to that of the emergency department for further management. On examination, we had seen that there was tachypnea, tachycardia, and there was no hypertension. The important thing is that there was no hypertension. So that means this child classifies for that of the heat exhaustion. Okay. However, this child, case 1, in this the hypotension had developed. So this child had developed into the phase of heat stroke. So I should identify the patients in the heat exhaustion state only. So let's come quickly how I would differentiate between these two conditions. So so the most common thing is that of the mental status of the child. Okay, so if the child is in the confused state, take care, and after taking some rest or after cooling the child, the mental status goes back to that of the normal. Okay, so that means the child is having heat exhaustion. Okay. However, if the child is having abnormal mental status means the child is unconscious, okay, or is having seizures, or having any feature of that of the encephalopathy, is saying abrupt words which are not fitting, is not aware of time, place, or person. So that patient is a case of heat stroke. So that's how even a bystander can differentiate this child is having a heat exhaustion, or this child is having a heat stroke. So if I take the temperature of that child, if usually in case of a heat exhaustion, it is seen that the temperature is less than 40 degrees centigrade or less than 104. However, in case of a heat stroke, the temperature is more than 40. So it is in between 104 to 105. If I look about that of the breathing pattern and the airway, the child will be having a normal breathing. There may be tachypnea or may not be there in case of a heat exhaustion. However, in case of a heat stroke, the breathing and the airway of the patient may be compromised. Coming to that of the circulation, tachycardia, it will be there in the both things, heat exhaustion as well as that of the heat stroke. The important thing is that the blood pressure will be normal in case of a heat exhaustion, and it will be reduced. Hypotension will be there in case of a heat stroke. Okay. So hypertension, we need to check about that of the blood pressure of a child. So the systolic blood pressure, there's a simple formula to tell about the upper range of that of the systolic blood pressure. That is 70 plus age into 2. Okay, 70 plus age into 2. Suppose the age of child is 4 years. So 4 into 2 is 8 plus 70, 78. Okay, so okay, I get a brief idea that the child is having hypertension if his systolic blood pressure is less than 78 mm of mercury for a 4-year-old child. Okay. However, there are more age appropriate charts are there for that of the child, but this thing can be used as a surrogate marker, which can be easily noted even in that of the periphery, how to measure a hypertension. Okay. Then another thing, how I would look about that of the child is having hypertension, I will feel the pulse of the child. If the pulse is quite feeble, then again the child might be having the hypotension. It is there. Okay. Then another thing is that in the circulation, there will be mild to moderate dehydration. And in heat stroke, the dehydration will be moderate to severe dehydration will be there. If I do the skin pinch in case of a child who is having heat stroke, it will be delayed and will be more than 3 seconds. And however, in case of a heat exhaustion, the skin pinch may be normal or it may be slightly delayed. Okay. And if the child is an infant, okay, and if his anterior fontanelle is open, I can see and I can palpate that it's quite it's sunken. Okay, it's very it's sunken quite high, so it's quite sunken more, and then it might be a case of heat stroke. So then in the skin findings, in heat exhaustion, I will find that the child is sweating excessively. However, in case of a heat stroke, we may get dry skin. Okay, so which is a classical heat stroke, and the child may not be sweating. The child may be sweating in case of an exertional heat stroke. In gastrointestinal symptoms, what I may see, there may be nausea, there may be vomiting in case of a heat exhaustion. However, in case of a heat stroke, the findings may be hematemesis, hematochezia, liver failure, or renal failure. So heat stroke is more in that of an extreme condition. So these are the 3 major differential diagnoses of a child who is having a heat stroke. There, the first is a fever. So in case of a fever, a simple fever, fever may be occur due to some infection also. So we may get a history that the child is having a cough, cold, and all those things, and other things we may get. We may differentiate it in that manner. Then another thing is that neuroleptic malignant syndrome. Neuroleptic malignant syndrome is seen in the patients who are on this antipsychotic medications, and if they are exposed to more dopaminergic drugs or any dopaminergic things, then they develop this neuroleptic malignant syndrome. And that's a major history. I will get that the child is on that of some sort of an antipsychotic medication. Then malignant hyperthermia. We know that when we expose, this is a common thing, which not so common. This is a thing which is seen when the patient is given a general anesthesia, then the child may develop the malignant hyperthermia. So we will get a history accordingly, and on the basis of its history per se only, we can differentiate about all these things by simple taking a history only. So coming to that of the diagnosis of the heat syncope and that of the other heat related injuries, the diagnosis is chiefly clinical, which has been said by that of the Ajay sir also. So it's majorly it's a clinical diagnosis only. So I do not need to perform a number of investigations keep this child is having some heat related injury. Okay, so I've just summarized and try to make a table over here. So these are the various heat related injuries in which the body temperature, it may be normal. Like in case of a malaria, heat edema and syncope, the body temperature, it will remain normal. In case of a heat cramps, the temperature may be normal or it may be elevated, and so may be a case of heat tetany, and it may be elevated up to 40 degrees centigrade or 104 degrees Fahrenheit. And in case of exhaustion, I will always get, or in case of a heat stroke, I will always get the temperature is elevated up to 104 degrees. In other conditions, the temperature may be normal. So this thing I need to just say. Other clinical features I have already covered in my previous slides. Now, coming to the treatment of that of the heat stroke. Other treatment I have covered simultaneously in those slides only. So the treatment starts at that place where the this event has occurred only. That means before the child had reached to that of the hospital, I should immediately start the treatment at that very moment only, so that those precious hours, the golden period, and that is not lost. Okay, so in case of a pre-hospital care, that means before the child has been brought to that of the hospital, the child is in the at home or in the playground or at school, wherever it is. So the person whosoever is there, if he's well trained in that of the in this medical trained, or if the coach is having a brief idea about the things in the like he's acquainted with that of the CPR, then he should assess that of the airway, breathing and circulation, and he should measure the core body temperature. Ideally, it should be measured the rectal temperature, but if rectal, it should be avoided in that of the pre-hospital scenarios, and it should be measured preferably in that of the hospital only. Okay, and the major thing is that we have to remove the clothes and athletic equipment. Suppose a child is there who is doing skating or is doing a bicycling. Okay, we need to remove his all the athletic gears, like I need to remove his helmets, I need to remove his knee guards, his gloves and all those things that should be removed. If he is wearing tight fitting clothes, those clothes needs to be removed, and simple any cotton clothes, they may be replacing those things, or a simple bed sheet which is of cotton, that can be given over that of the child at that very moment. Okay, so if the child is cooperative and is older and or adolescent, then if the possibility, if the feasibility of cold water immersion is there, that should be given to that patient. Okay, if it is not there, I should not be waiting कि नहीं हमारे पास तो cold water immersion नहीं है. Cold water immersion means simply even a bathtub जो है उसके अंदर आप normal, you can keep the normal water in the bathtub and let the child be there in that of the bathtub. So if that facility is not there, then what I need to do, I need to cover the head of the patient and neck of the patient with that of the wet towel. Okay, and just simply need to take a bucket, towel, put the towel in the bucket, just squeeze it and do a tepid sponging immediately. And in cases where the child is an infant or is a young child, okay, or immersion is not available, there simply the evaporative cooling with wet towel or sheets and a high flowing fan, it can be done. Okay, so what I need to do, I need to take a bed sheet and I need to dip in the water and squeeze it and wrap it around that of the child. And what I need to do, I need to keep my fan on that of the maximum speed, or use a high blowing fan and place it, face it towards that of the victim at that very moment. And I need to basically create a scenario where the evaporative cooling is taking place over there. Then repeat assessment of the temperature and vital signs. It should be done 3 to 5 minutes and should initiate the hospital transfer. That should be done over there. Okay, so these things, they can happen in the PHC level also. Okay, and PHC level also, and in the school also, and in the field or wherever the thing had happened. And even in that of the ambulance, till the patient had reached to that of the hospital, this care should be given. This is the important message over here. So once the patient or the child had reached to that of the emergency department, or what we say that to a tertiary care hospital and emergency room, I need to assess the airway, breathing and circulation, and neurological disability if it is there. So I need to do basically the triage of the patient at that very moment. What is the need? What is his need at that moment? Okay. So if needed, I need to do emergency intubation. And if there is a need, then I may consider giving the benzodiazepine for combativeness, seizures, or excessive shivering. Then I need to measure the core body temperature, rectal temperature. I need to remove the athletic equipments and clothing if had not been done previously. I need to apply the cardiac monitor, and rectal and esophageal temperature probe. They are preferable. These are the AHA under the CDC recommendations, but these things are not commonly there in our scenario. So even a normal pulse oximeter can also be used over there. Okay. Then important thing is that I need to establish the vascular access and evaluate for that of the associated complications. So associated complications, that means I need to evaluate simultaneously is the child is in the shock. If I'm placing a cannula but I'm not getting the veins, it's becoming quite difficult. And I'm checking the child, I'm just holding the child's hand, and I feel that the capillary refilling time of the child is prolonged. So the assessment should also be ongoing process. It should be also be an ongoing process whenever I'm providing the treatment up to the patient. That should also be done. Okay, then again, the same thing, that evaporated cooling with that of the wet towel and water spray, high flowing fan and cooling blanket, that can be given. And if the child is found to be in the shock, then I need to give a normal saline bolus. So this thing is important, that that normal saline bolus, it should be given at that of the room temperature. It's not that the child is a case of hyperthermia, so I will be using the cold saline bottles. No, it's not that. It should be used at that of the room temperature. And we know that we give the first bolus at the rate of 20 ml per kg. To a child, okay, slowly over 30 minutes, it's to be given, okay, and maximum I need it can be given up to 1 liter in total, okay. So maximum up to 1 liter. So I need to what I need to do, I need to give bolus 20 ml per kg. First bolus I need to give. Again, after that I will reassess the child. I will look up again, how is the heart rate, how is the respiratory rate of the child, how is the blood pressure of the child, am I able to palpate the pulses now which were feeble. So if the tachycardia is persisting, if the pulsations is still feeble, the BP, systolic blood pressure is still on the lower side, then I may consider giving the another bolus. Another bolus may be again given at the rate of 20 ml per kg. So after giving that of the second bolus, again I will again reassess the child. If the vitals are stabilized, I will stop at that moment. If again the child, I feel that the child is hemodynamically compromised, I will again repeat a bolus with that of the 20 ml per kg. So this is the third bolus. So in total, at maximum, I need to give a bolus. Maximum I can go up to the 60 ml per kg. So in the Alicots of 2020, 3 boluses, maximum going up to that of the 60 ml per kg. And there is a cap that on an average, the total amount of the volume of that of the normal saline which is going on, it should not cross that of the 1 liter. So that's how I will manage a child with that of the who is with that of the shock. So another thing I just wish to again stress upon is that we need to look about that we should also, whenever we give bolus to a child, to a newborn or an infant, to any of the child, we should always look about that the patient is not going into the sign of that of any fluid overload. Okay, so fluid overload should also be seen. So how I would look about that of the features of that of the fluid overload, I also need to monitor the child. I need to auscultate at that of the basal areas. I need to look about any new crepitations they are occurring or not, or is there any increase in that of the liver size? Is it so? Okay, liver size is also increasing, or rather than settling of that of the tachypnea or tachycardia, there is further it's not the condition that the tachypnea is also increasing. So I need to keep an eye that the patient is not going into the fluid overload. So the normal saline boluses, it needs to be given, but simultaneously I also need to monitor that the child is also not going into that of a fluid overload state. Then another thing is that I need to repeat assessment of the temperature and vital signs every 3 to 5 minutes. And I need to continue the cooling till the core temperature is brought to that of the 102 degree Fahrenheit. And if there is a end organ damage and there are complications, I need to manage them accordingly. So whatsoever is a complication end organ, I need to manage it accordingly. So end organ complication, suppose there is a ischemia and the brain is also brain has suffered some injuries and leading to some sort of seizures they are happening in the child. So I need to give medication for that of the seizures at that moment. So concurrent, I need to monitor the child for other organ damage also and manage the things accordingly. So this is basically a clinical workflow in that of the emergency department for management of the heat stroke in the children, which has been shared with you in the link. So first thing is that I need to do the primary triage. So once the patient comes to that of tertiary hospital, I need to do the triage and confirm the heat stroke. I need to assess the child for airway, breathing, circulation, simultaneously ensure an IV access, and send the relevant investigation. What investigations I would send? I would say do arterial blood gas, ABG. I will do a CBC. I will do electrolytes, sodium, potassium, and I will do the kidney function test, blood urea creatinine. Okay, so basically I need to look about that any dyselectrolytemia that is happening. Okay, how are the kidney function tests that is there? Okay. So those things I need to look about. So that's a basic investigation I need to look to send in the initial emergency. Okay. And if needed, the child's airway is compromised, then I need to manage the airway. If there is a child is having seizures or excessive shivering, I may use benzodiazepine like lorazepam or midazolam. Then shock, I've told you, if the child is in shock, then I need to give normal saline bolus, 20 ml per kg, and need to reassess, repeat bolus, and if necessary, I need to go up to 60 ml per kg. And continue the normal. Once the shock has been stabilized, then I need to start the normal maintenance fluid. In case, even after giving that of the fluid boluses, the shock is not compromised, then I need to start the patient on that of the inotropic support, like adrenaline or noradrenaline or dopamine. So whatsoever is my unit policy, according to that, I need to start the inotrope to that of the child. And if there is no shock, then I need to basically assess the dehydration status. If there is a mild dehydration, then I need to give the child 75 ml per kg body weight fluid over that of the 4 hours. If there is a severe dehydration, then I need to give the treatment of that of the severe dehydration. That means a total 100 ml per kg. So that I guess you must be knowing about how we do the management of that of the diarrhea in 30-70 we divide it. So I need to treat the dehydration if it is there accordingly. So so that's after maintaining of that of the vitals, then I need to institute active cooling measures, remove all the clothes while performing protecting patient dignity. Then I guess these things, they are quite common. They have also been covered. and it is said to avoid paracetamols and NSAIDs, and we may consider giving the gastric lavage or cold saline lavage that can be given to the child. And this is the points, 10 points which are there, how I need to closely monitor the patient who is having heat stroke. Temperature needs to be taken every 50 to 30 minutes. And vitals needs to be watched. In vitals, I need to look about the blood pressure, heart rate, SpO2. ECG, I may look about any changes in that of the ECG, and GCS of the patient. Then if I'm doing the treatment, I guess I have told you about this acute pulmonary edema. I need to look about that of the fluid overload if I'm treating. And hypothermia, I need to look about the child is not going into hypothermia. So again, the thing is that hypothermia is also notorious in case of the children. So I should be watchful whatsoever treatment is I'm doing. I'm not overdoing that treatment. Okay. So that's a treatment of seizures, and we treated with benzodiazepine. I use midazolam and lorazepam, and patient is shivering, and we may paralyze the patient. And if there is a feature of that of the DIC, DIC like features are there, so that means the patient is clinically having GI bleed or bleed from other sides, having a fatigue case, then I need to look about that of the platelet counts, and I need to look about that of a PT, APTT, INR, and accordingly I need to give the therapy. If there is a need of platelet, I need to give platelet. If there is a need of FFP, I need to give it there. If there is a need of vitamin K, I need to treat it accordingly. Okay. And ABG, I've told you. CT brain, to basically rule out if the child is not having any other complications. So suppose the child comes to you with scissors, he may be having something underlying, he might be having. So CT brain, it may be considered, but it's not that it needs to be done in each and every case. I need to take a detailed history also. And suppose if I'm getting a clear cut that the child was playing in the playing basketball and he fell down, and after that he had scissors, and so I guess there is no need of doing the CT brain in that case. And however, if I gets a patient who gives a history like that, he was also having scissors previously, and after during this heat stroke event, he again had a scissors. So I may consider doing a CT scan in that condition. So the investigation should be done, but it should be done judiciously. We should always think that we should not overdo an investigation, and we should continue management. And if the patient requires a more intensive care, the patient should be referred to a higher center. And we should, this is the most important thing which we always forget, that is a communication with that of the family. So we should always communicate with that of the family and tell them that your patient, we are taking care of him, or this is his patient, this is his present status. And or if he's sick, then he's sick, his level of severity is this, and I can manage this thing at my setup only. And your child requires a referral to a higher center, so we are arranging an ambulance, and do not worry, do not panic, and we will shift the patient to a higher center. So this is the most important thing, I guess. The attendants, they also need to be told about what is their parents, what is their children condition at that moment, else they become quite agitated, and it becomes difficult to even treat the patient at that very moment. So this is again a first aid instruction on heat stroke. This is shared with you, and that's how the symptoms of the heat exhaustion and heat strokes, they have been there in the manual. And that's how, again, the same repetition pre-hospital, how I need to take care of that of the child. Okay, so we need to bring the child indoors. Then I guess these things have been covered so many times, we can skip this. And that's how the preventive measures. So this is the most important thing, and I would again need to tell you that we should always look for that of the weather warnings, which by that of the Indian Meteorological Department, and teach kids to drink plenty of the liquids before and during after any physical activity in the hot sunny weather, even if they are not thirsty. So even we are having kids at our home, we should always tell about these things to our kids, that we need to look about these things. We need I should ask that the children, they should wear light clothes, loose clothes in warm weather. We should remind kids to look for shaded areas and rest often while outside, and should avoid going into that of the peak summer hours, that it means in between the 12 noon to 3 p.m. And should avoid that children you should avoid playing outdoor activities during that of the hottest hour. And whenever they feel they are not feeling well, they should come immediately inside. And this is the most important last thing, that never ever leave a child alone, not accompanied inside a parked closed vehicle. So this is said by that of the AAP. They say that look before you lock. So always look before you lock, that not lock your child alone in the vehicle. I'm just going to get this milk from the next shop. Let me just lock my child in the car. So should always take care of this thing. We should never lock the child alone. So this again I have taken from the manual only. This is the same thing. So that's the guidelines for the children going for that of the sports activity during the summer session. The children, they should be screened for any previous health issues, like the list I have already told initially. Then second important thing is that acclimatization. Okay, so changing zones for sports activity from cooler area to a warmer area. Suppose a patient, we are having some interstate sports meet here at Delhi. So, and we are getting children from that of the this Mandi side, Kullu, Himachal side, or from any JNK side, where the weather is quite cooler, and they come here to a warmer and a humid environment. So they should be acclimatized to warm weather, and they should be increased actively. That time of acclimatization, it should be gradually, it should be slowly over 1 to 2 weeks. Okay, and physical activity in hot weather should be increased slowly. That means first day I asked that a sports person to do only a 15-minute exercise. Okay, next 2 to 3 days I will say you do exercise only for 15 minutes. Okay, in next coming next 3 to 6 days, that then increase the span of that activity from 15 to 30 minutes, then so on. We can increase the span gradually. Okay, and exercise seasons, they should be shortened and made easier when it's hot. And athletic gear and grab, they should wear light colored garments that are light weighted and loose weighted, and they should be made from open weave and sweat wicking material to facilitate that of the evaporative heat losses. Okay, and the sweat saturated garment should be removed promptly. And so the amount of athletic equipment that should also be worn in increment steps. That means it's not that I have to go outside and do the skating. I will wear all the things in one go only. So no, it's not like that. For day one, I will just wear the cap. Then I will wear the gloves in the coming days. So it should be done in an increment steps, not in a single manner, the athletic equipment. Then athletes, they need to be hydrated adequately before going. Then again, that the timing of the exercise, they should be more during that of the morning hours and the evening when the temperature is closer. And the needs of these resuscitation equipments, they should be there, like cold water tubs, ice towels, they should be available whenever the athletic event is organized. Okay, and emergency action plan, it should be there. So I should be knowing this athletic event is going to happen here. So if something bad happens, okay, this is my first referral center, this is my second referral center. I should be knowing about all those things. So these things, the school administration and all those things, you can always tell them whenever you get a chance that these things, they needs to be taken care whenever we are whenever we are organizing any sports activity during that of the summer season. So these are the certain society guidelines on which are the links which are available. This I will share in that of the chat box. You can go through these documents also. These are the guidelines of the US as well as that of the UK. And so that's all about these things. And just briefly like to summarize now. And the 5 important messages I wish to give you, that the incidence is increasing and we need to increase awareness of the caregivers and the patients in preventing efforts. And heat stroke is different from that of the heat exhaustion. And how it is different, it's that in heat stroke, the temperature is more than 104 and there is a neurological dysfunction and altered mental status. And third thing, important message is that first line management of the heat stroke includes measuring a core temperature, assessing the airway, breathing and circulation, and initiating cooling. Fourth important message I would like to give is that counsel parents never to leave their child unattended in a vehicle. That means look before you leave. And we should aware the coaches and athletic trainers with the signs and symptoms of heat stroke and preventive methods. So that's all from my side. Yeah.
So thank you, Dr. Ankit Verma. Thank you very much for this detailed presentation that you gave. We have one more speaker for a short while with us. But before that, let me first thank you for the way that you explained it, the case studies, especially to make the people understand how the presentation may be of cases, the risk factors, why child are more vulnerable to heat conditions in compared to adult, the predisposing conditions, the pathophysiological mechanisms that work behind that, the spectrums of the health related illnesses that you mentioned, especially on the focus on the exhaustions and the heat stroke, also how in details you provided the management of the cases. Well, thank you with all of that. And just a few questions are available here, which if you could mind, I know you have to hurry for another meeting, so I'll try to see if you could answer some of them. I don't know, first question is something about if you could explain a bit more about conduction, if you mentioned in your slides.
Yeah, conduction. Yeah.
Yes.
Just a second. Sir.
Just a few more lines, if you could say on that for the audience. They just wanted to understand that concept a bit.
Yeah, sure, sir. Is my presentation visible? I guess I had unshared it. Just anyhow, never mind about that thing.
No, not even now. But anyway, okay, we can by the way time go back to the next question to put it, and then we'll see.
It's basically conduction is simply about that of the heat which is moving from that of the warmer to cooler surface.
Yes. Okay.
So that means simply that suppose I'm sitting. I've parked my car right now in the hot atmosphere outside. Okay, and I go there and sit on the car seat and even touch the my handle of the car, so the steering wheel of the car. So the heat which will be conducted, that will be the basically the mechanism over there. So that's a simple example of that of the conduction. Yeah.
Okay. The next question that I think I can see on the board is if you could talk about some key postmortem findings of heat stroke.
Postmortem findings I have not touched upon here in that of the children, but anyhow those things are similar to that of the adult patients only. Yeah, sir.
Okay. The next question is in you mentioned about cold water immersion. The question is, what should be the temperature of water at any specific temperature range for the water?
I was also checking the literature for the same thing, but in the guidelines, I could not get any specific temperature. So what I will do, I will search out and share it with you.
Okay.
The exact range. Yeah.
Sure. Then he says, do you have anything to say about what would probably be the changes in the pupils in terms of size and reaction in case of a child with heat stroke coming in ER in unconscious state?
Yeah, so there may be depending upon at what time the patient is coming to me. Okay, there may be meiosis also initially that may be there. Okay, and as Ajay sir had also told about that, I always need to differentiate between that the patient is coming is a case of that of the heat stroke to me, or basically is a case of that of the any poisoning. So I need to look about that of the pupils. So we may get meiosis over there. Yeah.
Yes, sir. Okay. Then he says, do we need to do liver function test in diagnosis of a heat stroke?
No, we do not need to do liver function test. When the first time the patient comes to me, it's not necessary that I will send an LFT at that very moment. But once, if the patient I have admitted and I'm giving intensive care to that patient, there I may need to send the liver function test of the child.
Sure.
Yeah, because the liver is again a organ which may be affected with time. Yeah, that can be there.
Yeah. He says, what would be the window period for taking action on a heat stroke cases?
It should be as fast as possible.
As
Yeah,
fast as
as
possible. I
fast
think
as
that was
possible.
also illustrated in the morning lecture. You
Yeah,
need to cool the patient at the fastest possible before you get into doing other things. So I think that's what you have also mentioned. And I also think in the question above that you mentioned, they may not know what the temperature range is, but cooling the case at the earliest possible is important. But as you said, that hypothermia is also a condition in the child, so you have to ensure that you don't put the case into an hypothermia by cooling too much. Am I right? That's what you mentioned in your slide.
yeah, you're absolutely right, sir. Another question which I could see in that of the chat box, what should be the rate of fall? So,
Yes.
so basically the main thing is that I need to monitor the patient and reassess the temperature every 3 to 5 minutes. Okay. And there is no specific rate of fall. It should be fall by this much rate per minute. Yeah, it should fall. So there is no mentioning of that of the exact rate. And however, it is said that we should continue the cooling until the core temperature is less than 102°F or less
Right.
than 38.9 degree. That is the thing which has been mentioned. So we should be taking
Yeah.
care about that thing. Yeah.
Yes. And can a neonate suffer from heat stroke?
Yeah, newborn is as much as susceptible for suffering that of the heat stroke, and because you know that they are having a larger surface area, and if the parents they are traveling, suppose they're traveling in a train and they have wrapped their newborn in a blanket and have excessively wrapped them, and it's a quite warm weather, they may suffer a heat stroke. And the basic principle for management again remains the same over there.
Same, right. And then again, he says at what body temperature can a heat stroke occur? I think that was in the very definition that you mentioned, core temperature being 40.5 and more. Is that the
Yeah,
answer?
sure, sir. Yeah, more than 104 degrees centigrade. Yeah,
Okay.
104 to 105. Yeah.
Why is it sometimes only the head of a forehead area is warm, rest of the body parts feel cold in clinical emergency settings, and the condition of the patient is with altered sensorium?
So because extremities, we know that there occurs a vasoconstriction. I had told about the thing in detail in my pathophysiological part. So what happens, the body, it tries to conserve the heat, and by doing the peripheral vasoconstriction. So whenever there is a fall in that of the cardiac output, so in order to maintain that fall in that of the cardiac output, the body starts to maintaining the systemic vascular resistance, and that happens by that of the peripheral vasoconstriction. And whenever it happens vasoconstriction, the extremities, they become cold, and the major blood is supplied to that of the brain as well as that of the heart. Yeah. to the vital organs.
So once again, thank you, Dr. Ankit Verma, with being with us. And we we have another speaker. We just recently on 9th and 10th had been to Ahmedabad, and we were like going around with all our program officers to various hospitals and centers in Ahmedabad Municipal Corporation jurisdiction, and we came across a wonderful work and done at LG Hospital Ahmedabad by Dr. Khayati Kakar and her team, and we talked about how the role of water and cooling in your and discussion and in the morning, and the role of wet cloth and fans to help in cooling of the patient. So with we will be now inviting Dr. Khayati Kakkar, who is the head and of the Department of Pediatrics from LG Hospital Ahmedabad, to share her views. Dr. Khayati, can you switch your
Yes,
camera
sir.
on?
Yes, sir. Can
Yes,
you?
you are
Yes,
on.
sir. Good afternoon,
Uh,
all.
Thank you, thank you. And
Um,
so what we would like is to share your experience with the pediatricians who have joined from various parts of the country, of how you have found positive results in your dome technique, please.
Yes, sir. Good afternoon to everybody. Sorry for not having PPT as I was rushed in a last moment of time as I was informed late. So Dr. Ankit has explained very nicely how heat-related illnesses in pediatric occurs. I will be focusing more on neonate, and my thing is more of sensitization. We did a study in our ward in a tertiary care medical college, and during summer 2020 we found that the occurrence of hyperthermia in otherwise healthy admitted neonate was more than 48%. So just imagine all asymptomatic baby, those who were lying in a maternity ward which was not thermostat, they have hyperthermia on screening, and all of them, approximately 85% of them, were asymptomatic, and mother were not knowing about the hyperthermia. So neonates are the more vulnerable population because like in children, they just can't speak or they just can't express. So we need to be more vigilant to pick up hyperthermia in neonate. And all other causes of septicemia and most of the things, they present as a hypothermia rather than hyperthermia. So hypothermia is given so much importance in neonate, but hyperthermia, which causes morbidity, has not given that important. And we see most of the neonates present during summer months with hyperthermia. Associated comorbidity will be AKI, hyperthermia, the occurrence of jaundice, dehydration, and weight loss. So my important message is to be sensitized towards occurrence of hyperthermia in neonates. It is much more common than we assume, more common than in pediatric and in adult, because the poor neonate doesn't speak. And the method of heat passage, that conduction, convection, radiation, and evaporation, acts very significantly on neonate more than it acts on pediatric patient. So on a preventive aspect, if I want to share my experience, that if a baby, we explain them a dome technique. Purvi, can you please share that? So sorry, I have not prepared any slide, but I would like to share my experience. The next slide, which explains what we advise to all neonates who gets discharged. They not necessarily they are hyperthermic or they are normal, or normal neonates. We ask mother to buy this umbrella shaped mosquito net, which is readily market may available, and it will not cost more than 100 rupees. So we ask mother to put the baby inside the mosquito net, and a soft mull cloth or a dupatta, we ask them to wet, squeeze, and just wrap it around this mosquito net. So when the water will get evaporated, it will provide the cooler micro environment to the baby. And it is very useful, very acceptable by the mother. I have been using this technique for last 10, 12 years. No hazards I have noticed. As Dr. Verma told rightly, because we need to be careful for hypothermia in neonate. So we just can't wet the baby neonate directly with the wet cloth like we do in a pediatric patient. So to prevent hypothermia occurring in a neonate, this is a very effective technique. And we found that in our study, it reduces the occurrence of hypothermia by 40%. And even though baby has developed hyperthermia and temperature is not 102 in neonate, 102 more we admit in a NICU, we keep baby under this mosquito net, and in 75% of the cases, the temperature reduces by 4 hours. So this was my experience to share. It's a very easy technique for neonate. And hydration also is very, very important for neonate. So if encourage mother to drink more water, encourage mother to breastfeed baby often, and have a check on baby during summer months. Baby should not be lying directly under the sun near the window, and baby should not be unattended. So that's what I want to share.
Thank you. Thank you, Dr. Kayati. And your initiative, I will probably was very innovative and would be helpful to a lot of people who are watching it all over. And I'm very sure you will also bring it out on some journal for people to understand the scientific concept behind it.
Yes.
And so to everyone who is joining with us here from all across the country, the program officers from the state, from the district, and the clinicians, medicine specialists, pediatricians from across the country. Thank you for being with us today. We had all been very recently to Ahmedabad and witnessed how at the hospital level and even at a community center level, a lot of initiatives have been taken by the city in trying to be heat resilient. They have provided for wards, even at a community level health center, to take care of the patients. As you all know, cities like Ahmedabad are really very vulnerable to heat situations in summers, and I'm very sure many other parts of the country have similar issues. And what we saw was a small room which was not placed at the top floor in the health center, and it had a very good ventilation opportunity, cross ventilation facilities. There were very light curtains so that there was no obstruction to airflow. Each bed had a fan right on the top of it, so there was proper air ventilation to the given patient. Uh, Air condition was available in the hospital, but in the community health center, they had provided for a big size cooler for the same purpose to bring down the temperature. They had also provided for uh, ice packs in the room so that they could be provided to the patients when they are brought in. A solar powered cooler was available for availability of drinking water for the patient as well as for the attendant. They provided for green shading all around the campus so that patients who come in the afternoon hours when the sun is at height are not affected by the heat. In the center, there was IEC center right in the middle of the health center. There was an ORS corner also with IEC material. So uh, a lot of input had been provided by a community level health center in Vatwa at Ahmedabad, which was an example which I believe for most of the health centers and hospitals can think of in their own settings. Please, in the morning also, we heard from the specialist that how he in his practice days had seen such settings been put up where he was working previously, and it is recommended that all cities and districts which are affected by heat conditions, that the program officials work with the hospital administration, with the health center administration to identify where patients suffering from heat conditions can be brought in and provided care. And we heard from three specialists today, and I'm hopeful that you all will take it forward in your own cities, in your own hospitals, in your own places. These trainings will be available to the program and district officials, and they are requested there after to further disseminate these training materials of PPT and recordings with the clinicians who have participated in the training today, and use those clinicians and work with them to impart further trainings to your other clinicians in the state and district who could not join today. Many had requests about providing these discussions in Hindi and in languages of their own state, but I can only say that that would not be a possibility from our side. So therefore, what I have said, that once you have the master trainers on board, master trainers and the officials are requested to take it further to their own places in their languages, so that it becomes easier for the local clinicians to understand the concept with clarity. And with that, I would like to thanks all the experts and Dr. Khayati Kakkar, who at a short notice joined us from Ahmedabad. And also, um, I have a request that all the clinicians, pediatricians, and medical specialists who have joined today, please be a part of this initiative to work on climate change and health. It's a very broad subject, and it's a hidden killer. It's something that people don't talk about much, but you, the who bear the responsibility of dealing with the patients, will take. If you share this responsibility with the program, you will probably help us in taking this forward. And at the end, once again, the recordings will also be available at the NPCCHH YouTube channel, where recordings from the previous similar trainings and seminars are also available for all the program officials. And I will request the program officials to please bring in all the connected professionals who are interested in working in the program to be connected to the WhatsApp group that we have for the district levels, so that they can be also timely be aware of what activities we are doing. When we have training programs or seminars, if interested, they can also join and listen to them, and access be provided to them of the materials that are available. We have an NCDC website with a section available for the program, where also we upload all the documents, recordings, and PPTs that we are able to gather after such discussions. We very soon are possibly going to have our own website, and then we'll let you know uh, about that. So once again, thank you everyone for being with us, and I will request Dr. Purvi to say the closing word before we conclude with the session.
Thank you everyone for joining us since morning. It has been a long session, but I hope it was a lot of information for you to learn and disseminate. Thank you, Dr. Aakash, for moderating it, and Dr. Chati for joining in the last minute. That's it, and we'll be in touch with your program officers and convey everything to you eventually. So thank you and have a good day.
Thank you.